So good morning. I'm Michael Gnant from the Medical University of Vienna, and also on behalf of Zhi-Ming Shao from Fudan University and Cancer Center in Shanghai, China. It's my privilege to welcome you to General Session 2. We have quite a number of exciting presentations. So if you have not yet done so, scan the QR code in between and submit questions for our discussion. Let me call the first presenter, Icro Meattini from Florence, Italy, presenting on exclusive endocrine therapy or radiation therapy in women aged 70 plus with luminal-like early breast cancer, a pre-planned interim analysis of the randomized EUROPA phase 3 trial. Icro.
Thank you, Michael, for the nice introduction. On behalf of the EUROPA Trial Steering Committee, I would like to thank for the selection of our contribution. These are my disclosure information. So a bit of background, basically based on the breast cancer in older adult women. We know that this is a high prevalence of breast cancer in estrogen receptor positive stage 1 breast cancer, especially including patients aged more than 70 years old. So basically, to reduce the treatment burden and try to balance the treatment efficacy and side effect, including health-related quality of life, is crucial. However, currently, the current standard of care is still breast-conserving surgery for the vast majority of these patients, followed by postoperative radiation therapy, and the majority of these patients receive adjuvant endocrine therapy. From the past, this is the study rationale and objective challenges from the previous studies. Unfortunately, all the older adult radiation omission only, unfortunately, trials demonstrated that basically if you omit radiation therapy following the primary hypothesis of the phase 3 trials, you obtain a significantly higher risk of local relapse. At the same time, we have to take into account the side effect and adherence, persistence challenges, issues related to the endocrine therapy in these potentially fragile patients. So there's the need for a direct comparison between endocrine therapy and radiation therapy. We acknowledge a lack of data comparing a single modality radiotherapy and single modality endocrine therapy after breast-conserving surgery for patients aged more than 70 years old. So this is the objective of the EUROPA trial. Evaluate health-related quality of life, at the same time local control has two co-primary endpoints and having a direct comparison between the two treatment arms. This is the trial design. Basically, this is a phase 3 trial. Overall will be 926 patients, breast-conserving surgery, with or without sentinel node biopsy of patients affected by PT1 and 0 or CN0 invasive breast carcinoma, estrogen receptor on progesterone receptor positive more than 10%, Ki67 less than 20%, HER2-negative patients, age more or equal to 70 years old. Randomized 1-to-1 to receive single-modality postoperative radiotherapy or single-modality adjuvant endocrine therapy with two co-primary endpoints: health-related quality of life as measured by global health status at 2 years and ipsilateral breast tumor recurrence at 5 years. Following these stratification factors, age class 70-79 as compared to 80+, and geriatric age tool score less than 14 as compared to more than 40. Treatments. This is real pragmatic trials. So radiotherapy arm can be hyperfractionated whole breast or partial breast irradiation with favor the 5-fraction and partial breast irradiation following the international guidelines, and endocrine therapies as well, aromatase inhibitors or tamoxifen, 5 to 10 years as per treatment physician choice. So it's a pragmatic study. Statistical assumption. This is, of course, an interim analysis and was pre-specified, pre-planned when the first 152 patients enrolled reached the 2-year global health status health-related quality of life follow-up control. We had also to check stopping rules in terms of local control and distant metastasis. Of course, at the very end, the overall number of patients randomized in this trial will be 926 patients. Of course, the health-related quality of life is a complex analysis based on the EORTC, C30, and BR45 model. Patient characteristics. That's basically the vast majority of patients have an age class of 70-79, so really not more than 80. 74% of patients around had 70 to 79. And G8 score class, they are fit patients. More than 60% of patients has a score more than 14 points. Concerning other important characteristics, the majority of patients had tumor more than 5 millimeters, so it's PT1B, PT1C, 90% of patients around, and not G1, the 65% of patients has a G2 tumor. So it's really a wide population. Primary endpoint result, CLQ, C30, global TEL status. That's it. The blue line is radiotherapy, the red line is endocrine therapy, the higher, the better. This is the empirical least square mean change from baseline to 24 months. Radiotherapy arm, this is decreased change from baseline, between baseline and 24 months, around 1 point. If you look at the endocrine therapy arm, they change from baseline to 24 months, is around 10 points. If you look at the adjustment following the age and G8 class, again, there's no significant difference between baseline and 24 months in the radiotherapy arm. There is a significant difference in terms of decrease of health-related quality of life in the endocrine therapy arm. And already now there is a preliminary analysis, the mean difference between the two treatment arms, this is a primary endpoint of the study, is statistically significant. This is exploratory analysis, of course, since it's an interim analysis. The C30 functional scales, radiotherapy arm basically showed a better performance as compared to endocrine therapy for most of the functional domains, so physical, emotional, cognitive, and social functioning. Here, the higher, the better. If you look at the C30 symptom scales, here, the higher is the worse. Of course, radiotherapy arm, again, showed better outcomes as compared to endocrine therapy arm for most of symptoms domains. Consider that this is an exploratory analysis, of course. B45, this is really important, functional scale breast module is the higher, the better. No statistically significant difference between radiotherapy and endocrine therapy arm for most of the functional domains. And concerning symptom scales, we already are able to see some important signals. Radiotherapy arm course show better outcome as compared to endocrine therapy arm for most of symptoms domains. And here, endocrine therapy shows statistically significant worse in terms of systemic therapy and skin mucosis symptom scores as compared in the comparison group. Survival outcome. This is an interim analysis, but at 24 months, we have no ipsilateral breast tumor recurrence, as expected, and local regional relapse in both arms. No distant metastasis, no breast cancer-related death. Very important, adverse events. Treatment-related, treatment-emergent adverse events showed 67% of occurrence in the radiotherapy arm as compared to 85% in the endocrine therapy arm. There is a difference of around 20% between arms in favor of the radiotherapy arm. That it means, if you look at this table with all the grade 1, 2, and grade 3 or plus, and here highlighted the occurrence of more than 20% adverse events, that the profile of endocrine therapy is much, much better in terms of adverse events. And means that 22.5% at 24 months already of patients in the endocrine therapy arms needed a switch in the endocrine therapy kind, and 12.4% already needed an endocrine therapy permanent discontinuation, and this is only 24 months. The current status of the study. This is a multi-center Italian and Slovenian study, 21 recruiting centers. At today, 858 patients, 92% of patients have been enrolled. We are going to close the study in 2 months. Of course, we have to acknowledge some limitations. This is an interim analysis based on a subset of planned cohorts. Limited long-term efficacy and safety data should be acknowledged. So the follow-up duration is a median follow-up of 24 months. So the long-term outcomes is pending. And there is, of course, a generalizability acknowledgement for this luminal-like breast cancer patient age more than 70 years old. However, the conclusions of the study, in this interim analysis, we already evidence that radiotherapy may offer a better health-related quality of life as measured by global health status preservation as compared to endocrine therapy at 24 months. We evidenced the lower incidence in terms of treatment-related, treatment-emergent adverse events in the favor of the radiotherapy arm, and no warning signal regarding stopping rules in terms of disease control. Of course, future directions, ongoing patient recruitment and follow-up. Final analysis, of course, will include the co-primary endpoint of ipsilateral-based tumor recurrence, so hopefully we'll be here in some years. And the take-home message, really, really important. Radiotherapy or endocrine therapy might be a suitable, viable, single modality treatment option. We are accumulating data, so we should always emphasize the need for a true multidisciplinary and a true patient-centered personalized care. I would like to thank patients first and their caregivers, importantly in this patient population, all the investigators, the participating centers, Fondazione Radiotherapia Oncologica that supported for non-profit a pure academic trial, all my colleagues in Florence, the EUROPA investigators, the study coordinators, Lorenzo Levi and Philip Portmans, all the steering committee. If you are eagerly waiting for details, I'm proud to announce that the EUROPA trial will be published today after the general session in the Lancet Oncology. Thank you very much for the kind attention.
Thank you, Icro. Questions from the floor? Microphone 2.
Peter Dubsky, a surgeon from Lucerne. Congratulations, first of all. Maybe we missed it, but we were looking for how many of these patients had ultra-hyperfractionation, so very short courses.
Yes, in this interim analysis and in general, currently in the world study, 85% receive partial breast irradiation, the majority with ultra-hyperfractionation, so the 5 fractions. And concerning endocrine therapy, that for the sake of time, of course, there's no chance the majority receive aromatase inhibitors. It's 80% of aromatase inhibitors, 80% of partial breast irradiation. Thank you, Peter, for the question.
Microphone 6.
Great.
Vogel, New York, very nice paper. Kevin Hughes, in his study that was first published about 20 years ago of radiation versus not for a similar patient population, reported a lot of ipsilateral pain that lasted years in the radiated patients. Did your quality of life and instruments pick that up?
Yeah, of course, we are going to record all these data, and this is something that we should take into account. As I said, I think this is not a challenge between radiotherapy and endocrine therapy. We just try to highlight the profile of these two treatments in order that the treatment physician can really choose the best for the profile of patient that they have run. And this is something that should be taken into account, of course, I think.
So do you have any data on it to tell us today?
We have data also on that, yeah. We will collect at the end. Thank you for the question.
Last question, microphone 3, Professor Robertson.
Thank you very much. Really good to see your study, and I think I'd like to emphasize it's great to see an academic-led study, so congratulations on that. You obviously said you need longer follow-up, and there's no one thing that predicts risk in breast cancer, but the group that we're probably really interested in is the grade 3 patients, 1A, 1B, 1C, grade 3. I can't remember what percentage of those patients you have in your study, and do you have enough power to look at that group who are at the highest risk? For sure.
Thank you for the question. In the trial, tumor grade 3 was, of course, an inclusion criteria for tumor size less than 1 centimeters, otherwise any grade for all. But currently, and you will see in the publication of data, we have no G3 patients randomized. So probably the generalizability of this study will be for G1, 2 patients when really we are going to omit one or the other for this selected population, of course. Thanks for the question.
Okay, one final quick question, microphone 6.
Barb Schwartzberg, California. Obviously, your radiation patients are 100% compliant. How many of your endocrine therapy patients have discontinued the trial due to side effects?
Yeah, Concerning adherence, you said,
I mean, there's 100% compliance with radiation.
yeah,
How many ET patients have dropped out due to side effects?
22.4% at the current analysis. So this is expected to increase for the final analysis. We know the adherence of treatment, thanks for the question, it's really crucial for these patients. Thank you.
Thank you.
Okay, thank you.
Thank you very much.
Okay, the second speaker will be the impact of the tamoxifen only after breast conservation surgery for good risk duct carcinoma in situ. Results from the NIG Oncology, RTOG 9804 and ECOG-ACRIN E5194 trial by Jane Wright. Dr. Jane Wright, please.
Good morning. Thank you so much for the opportunity to be here today and to present our analysis evaluating the impact of tamoxifen only after breast-conserving surgery for patients with good risk ductal carcinoma in situ. This is a combined analysis from the NRG Oncology RTOG 9804 and ECOG-ACRIN E5194 trials. I have no significant disclosures. The impact of radiation therapy on ipsilateral breast recurrence, or I'll refer to as IBR going forward, after breast-conserving surgery for DCIS has been the subject of extensive research, including the randomized RTOG 9804 study shown here. This was a study that randomized patients with good risk characteristics for DCIS to radiation therapy versus no radiation therapy. The 15-year results shown here show that radiation therapy reduced IBR by about half, from 15% to 7% at 15 years of follow-up. So this study identified that while radiation therapy does reduce the risk of IBR, that omission of radiation therapy is also a reasonable option for patients with these good risk DCIS characteristics. The impact of endocrine therapy has been a little bit less well studied, particularly in the modern era. Historical data shows variable impact of tamoxifen on IBR. For example, in the NSABP B24 study, in which all patients received radiation therapy and were randomized to receive tamoxifen versus no tamoxifen, tamoxifen reduced the incidence of overall IBR and invasive IBR, but not DCIS IBR. And conversely, the 2x2 factorial UK DCIS trial showed the opposite impact, with tamoxifen reducing DCIS IBR and not invasive IBR. So in this setting, most modern studies of DCIS have actually left the use of endocrine therapy at the discretion of the patient and the physician, and practice has been highly variable. So this combined analysis of the RTOG and ECOG-ACRIN studies looked at patients who were classified as having, quote, good risk DCIS. The RTOG study was again randomized radiation therapy versus no radiation therapy, and all patients had characteristics including DCIS span less than 2.5 centimeters, grade 1 to 2, and margin width 3 millimeters or greater. The ECOG-ACRIN study was a prospective observational study of patients who had breast-conserving surgery without radiation therapy. There were 2 cohorts, and one of those cohorts had the same good risk characteristics as those included in the NRG RTOG study. In both of the trials, the use of tamoxifen was optional, but was tracked. This is a table that depicts the groups included in the 2 studies. I'll highlight that we looked specifically at the good risk patients in the RTOG study who did not receive radiation therapy, and the patients enrolled in E5194 who were in the cohort 1, which had the same good risk characteristics. So combining these 2 data sets, we were able to identify a group of patients with good risk characteristics for DCIS who did not receive radiation therapy, a total of 878 patients. Looking at tamoxifen utilization in the 2 studies, this reflects the variability in practice that we do see. In the RTOG study, 66% of patients took tamoxifen, whereas in the ECOG-ACRIN study, only 30% of patients took tamoxifen. Our methods are described here. In brief, we looked at the cumulative incidence of overall IBR, invasive IBR, DCIS IBR, and contralateral breast events, and compared those events with respect to the utilization of tamoxifen. Patient characteristics are shown here. We can see that other than the utilization of tamoxifen itself, the groups were well matched with respect to age, menopausal status, and race. The median patient age across both groups of tamoxifen versus no tamoxifen was 59. Most patients were postmenopausal, and the majority of patients who were enrolled were of white race. Looking at the DCIS characteristics, the enrollment criteria for both studies was that the margin width be 3 millimeters or wider. So we acknowledge current guidelines require 2 millimeter margins, so these margins are slightly wider in general than what we might see in common practice today. With respect to pathologic size, while the inclusion criteria for both studies was DCIS span of 2.5 centimeters or less, when we look at patients enrolled on the study, the DCIS size was relatively small, with most patients having 1 centimeter or less in terms of the pathologic size. Looking at the grade of DCIS, at the time of enrollment, all patients were defined as having either grade 1 or grade 2 DCIS. After enrollment was completed, a central pathology review was conducted of the ECOG-ACRIN patients, and a subset of patients who were originally enrolled into the lower intermediate grade cohort were upgraded to have grade 3 DCIS. So there is a small subset of patients in this analysis that are now defined as having high-grade DCIS. The impact of tamoxifen on overall IBR was to significantly reduce the 15-year risk from 19% to 11.4%, and this was a statistically significant reduction. Breaking down IBR into DCIS IBR and invasive IBR, we can see that tamoxifen had a small and non-significant impact on DCIS IBR, but had a statistically significant reduction in invasive IBR at 15 years from 11.5% to 6%. Contralateral breast events were actually uncommon in both groups and were not significantly impacted by tamoxifen, 8.8% versus 5.6%, and non-significant. Univariable analysis looking at factors that may correlate with the risk of IBR showed that pathologic size and DCIS grade, in addition to tamoxifen, were correlated with overall IBR risk. Multivariable analysis looking at overall IBR showed that both tamoxifen use and pathologic size, specifically less than 5 millimeters versus greater than 10 millimeters, were significantly associated with IBR outcomes, while DCIS fell out of the model on multivariable analysis. Breaking down IBRs into invasive and DCIS IBR, we can see that both tamoxifen use and DCIS grade 1 versus 2 retained statistical significance for invasive IBR, while pathologic size fell out of the model. And with respect to DCIS IBR, only pathologic size retained statistical significance, and DCIS grade fell out of the model. This forest plot shows subgroup analysis for overall IBR. We can see that the hazard ratio either was reduced or trended toward being reduced for all subsets of patients, showing a broad benefit to the utilization of tamoxifen. So in conclusion, this exploratory analysis combining the two data sets, NRG RTOG 9804 and E5194, demonstrates that patients with good risk DCIS defined by clinical and pathological criteria and treated without radiation therapy, tamoxifen reduces the risk of overall IBR significantly from about 19% to 11%, and invasive IBR from about 11% to 6%, but did not significantly impact DCIS, IBR, or contralateral breast events. In the absence of survival impact for adjuvant therapy, the decision to recommend endocrine therapy or radiation therapy should be part of a shared decision process, and I think that this data helps us provide clearer data points to our patients to help them make choices between endocrine therapy and radiation therapy in the setting of good risk DCIS. The next studies will really focus on the impact of molecular profiling to inform adjuvant therapy decisions. There are a number of studies ongoing or in development that focus on molecular profiling to inform radiation decisions, but we should also evaluate the potential impact of those tests on the ability to predict endocrine therapy benefit, particularly for those patients who choose not to receive radiation. I'd like to acknowledge our co-authors who are listed here, as well as the patients and the institutions who participated in these trials. I would also like to acknowledge the leadership of Dr. Julia Wright with respect to the initial RTOG study, as well as Dr. Larry Solin, who was the original lead author of the E5194 study. Dr. Solin passed away in 2020, but had long hoped that this combined analysis would be possible. So we're very pleased to be able to present these results for his legacy. Thank you so much.
Okay, thank you. Any questions? Okay, microphone two, please.
Really interesting presentation. John Robertson, Derby, UK. Really interesting presentation. Two questions. One is, why do you not see a contralateral effect, but you seem to see it in the treated breast? Everything else is what you would expect with tamoxifen. So one, how do you explain that? The second thing is, does this study not tell us something about the effect of surgery, breast-conserving surgery, in the sense that it's a field effect that you're seeing, and you do need something else? And we presented data last year from the NHS in England, 17,000 patients, and actually 80% of the patients who got recurrences were invasive cancer. So I think this might make us have to think again when we talk to patients that it's not the same as invasive cancer, where breast-conserving surgery plus radiotherapy is the same as a mastectomy. You're comparing two different things with surgery and the different types. So contralaterals, sure. And is it a field effect, and how does that affect the primary surgical local treatment?
Sure. So I think many of us were surprised by the low incidence of contralateral breast events overall and the minimal impact of tamoxifen on that outcome. I think that one important feature of the patients included in these studies were that they were very carefully kind of selected definition of good risk DCIS. And even though, as I presented earlier, the allowed extent of DCIS was up to 2.5 centimeters, really most patients enrolled in this study had very, very small focus of DCIS. So it may just be that this is a slightly lower risk group than other studies that have looked at DCIS. But I would acknowledge that that was a surprising result, I think, for all of us. And with respect to the impact of surgery, I mean, all of the patients here had breast-conserving surgery. The data, I think, also shows us what the outcomes would be without any adjuvant therapy at all. And as I suggested in my conclusions, in the absence of a survival benefit, I think that there are still some patients who might choose not to have any adjuvant therapy after breast-conserving surgery. But this really allows the patient to, make a choice amongst all of these various options that they have.
Yeah.
Microphone one. NYP Brooklyn, and Astro, NYP Brooklyn Methodist. In light of the previous presentation, do you want to comment on quality of life considerations with the different modalities?
Sorry, could you repeat the question?
Would you want to comment on quality of life considerations in light of the previous presentation?
Yeah, so these studies did not specifically, or this analysis did not specifically track quality of life. And we just heard in the previous presentation that there could be significant differences in quality of life when choosing between radiation therapy and endocrine therapy. So I think that it's important to consider a patient's priorities, perhaps their comorbidities, baseline conditions that may make one treatment choice more preferable for them as compared to the other. So certainly quality of life has to be considered in making these types of decisions on a patient-by-patient level.
Thank you.
Okay, final question number 5, microphone. Do they have questions?
Hi, my name is Hans-Christian Kopeck. Thank you from Germany. Thank you for the excellent presentation. I have a question regarding ER and PR. Do you have any data about ER and PR of the DCIS originally? Because that may have influenced the decision and the discussion of the physician with the patient about tamoxifen, yes or no. And the second small question is, do you have any data about ER and PR of the invasive breast cancer distribution? So the question is, does tamoxifen inhibit only the evolution of ER-positive breast cancer or not?
Sure. So ER status was known in the ECOG study and not known in the RTOG study. What we see is that the majority of patients enrolled in the study, based on extrapolation, would have had ER-positive disease, but it's certainly a limitation that we don't have that information on every single patient. I don't have the information on the ER status of recurrences.
Okay, thank you very much.
We have quite a number of interesting questions coming in from the virtual room, so please, whatever cannot be answered here due to time constraints, put it on the app, and I ask the presenters to answer the factual questions and some of their opinions. Next presentation will be given by Ian Kunkler from the University of Edinburgh in Scotland. Does postmastectomy radiotherapy in intermediate risk breast cancer impact overall survival? 10-year results of the big 204 MRC randomized trial SUPREMO. Ian.
So I'd like to thank the organizing committee for the opportunity to present the 10-year results of the MRC International SUPREMO trial testing the value of postmastectomy radiotherapy in intermediate risk breast cancer. I have no financial disclosures to make. Nearly 3 decades ago, landmark trials from the Danish and Canadian groups established that giving comprehensive local regional irradiation to patients who were predominantly node positive resulted in both pre- and postmenopausal patients in a 9 to 10% overall survival benefit. And on the basis of this data, postmastectomy radiotherapy became the standard of care for patients with T3 tumors and those with 4 or more positive nodes. But there were concerns about the quality assurance, particularly in the Danish trial, in terms of the limited number of nodes removed from the axilla, the intensity of the adjuvant systemic therapy, and the relatively high local regional recurrence rates at 10 years of over 30% in the non-irradiated arm. And on the basis of this uncertainty, postmastectomy radiotherapy was made a research priority of the National Institute of Health Research, National Institute of Health in the US in 2000. So the eligibility criteria for SUPREMO were patients with PT1N1, T2N1, or T3N0 invasive breast cancer, or PT2N0 with additional risk factors, either grade 3 histology or lymphovascular invasion. So these patients have had a mastectomy with at least 1 millimeter margin. They had to have 8 nodes removed. They had to be, if they were node positive, then it had to be on the basis of an axillary node clearance. But if they were node negative, then that could be on the basis of node sampling or a sentinel node biopsy. And they had to be fit for both neoadjuvant or adjuvant systemic therapy, endocrine therapy, and radiotherapy. So the primary endpoint was overall survival at 10 years, and the secondary endpoints were local and regional recurrence, disease-free and metastasis-free survival, which I'm presenting today, but but I'm not presenting the secondary endpoints of cause of death, morbidity, quality of life, and cost effectiveness. So the final powering of the trial was 1,600 patients for 80% power for a statistically significant difference at 5% level if the rates of survival at 10 years were 56% in the non-irradiated group, 63% in the irradiated group, allowing for attrition and a 7% difference. And this corresponded to a hazard ratio of 1.255. So this is the consort diagram. So these patients were randomized between 2006 and 2013. There were 1,679 patients who were randomized, and taking account of those who were non-eligible, it left us an intention to treat population of 1,607, 799 in the non-irradiated group to the left of the panel, and 808 on the right. And these were irradiated with conventional regimes between 40 and 50 gray in 15 to 25 fractions, with a data log at the 19th of June 2024, and a median follow-up of 9.6 years. So these are the basic characteristics of the trial, which were well balanced for age, grade, number of nodes, tumor staging on the right-hand panel, and 1,201 were 1 to 3 node positive, 402 were node negative. We've got 40% with 1 node, 22% with 2 nodes, 12% with 3 nodes, and just over 20% were HER2 positive, and 10% were triple negative. So the overall survival at 10 years was 82% in the non-irradiated group, 81.4% in the irradiated group. There was no statistically significant difference between the irradiated group in blue and the non-irradiated group in light brown. The hazard ratio was 1.04 with very narrow confidence intervals of 0.82 to 1.3, giving a high degree of precision. Analysis by a pre-specified subgroup analysis of overall survival by nodal status, showing the node negative patients on the left and the node positive patients on the right, showed no differences with or without irradiation. In terms of chest wall recurrence, there was an effect of chest wall irradiation on chest wall recurrence, and although the relative risk reduction was over 50%, the absolute difference was very small. So we've got a hazard ratio of 0.45 with a p-value of 0.4, but you'll see that the number of local recurrences was very small, only 29 in total, 9 in the irradiated group, and 20 in the non-irradiated group, a difference of less than 2% that we've not think is clinically significant. And we've just shown in the right-hand panel the difference where we've amplified the y-axis between the irradiated and the non-irradiated group. And then when we look at chest wall recurrence by nodal status, there is no difference between the N0 and the N+ patients. When we look at regional recurrence, there's a weak effect of radiation on regional recurrence, with a hazard ratio of 0.61 and a p-value of 0.6. When we look at regional recurrence by nodal status, again, there is no difference between the N0 and N+ patients. When we look at metastasis and disease-free survival in the left-hand panel, the metastasis-free survival, there is no difference there. Got a hazard ratio of 1.06 and a p-value of 0.60. On the right-hand panel, you can see the disease-free survival with a hazard ratio of 0.97
and a p-value of 0.70. So, in conclusion, in patients with 1 to 3 positive nodes or node negative with other risk factors, adjuvant chest wall irradiation does not improve 10-year overall survival. It results in a clinically insignificant reduction in chest wall recurrence of less than 2%. It has no impact on disease-free or metastasis-free survival, and we think that incremental improvements in multidisciplinary care probably explain the results, and that adjuvant chest wall irradiation should be omitted in most patients meeting the eligibility criteria for SUPREMO. And I'd like to acknowledge the patients who participated in the trial, the participating trial groups, the administrative centre of the trial at Public Health Scotland, the trial steering committee, the trial management group, the data monitoring committee, and our principal funders from the UK MRC, the NIHR, the EORTC and URTC Breast Group, the Dutch Cancer Society, Cancer Australia, and the trustees of the Hong Kong and Shanghai Bank. Thank you for your attention.
Thank you very much, Ian. Let's start with microphone 5.
Hello, this is Guilherme Novita from Brazil. The type of mastectomy is always radical modified mastectomy, or are there included nipple-sparing mastectomy in the analysis?
All these patients had a simple mastectomy.
Microphone 6.
Congratulations on completing the trial. Yusuf Zaidan from Baptist Health, Florida. My question, many of these patients in practice today and in light of trials comparing axillary dissection versus axillary radiation therapy are getting omission of axillary lymph node dissection. So what are your thoughts on guiding modern practice in the setting of omission of axillary lymph node dissection in this patient cohort?
Question about exhibition. So this is a good question, because clearly the practice of axillary management has changed. So the context of this trial, all the patients had an axillary node dissection, but there's obviously data from the Amaros trial that in patients with 1 to 2 positive nodes that radiotherapy may provide an alternative. So I think it is possible that with targeted radiotherapy, which has moved away from field-based radiotherapy to targeted irradiation with VMAT and IMRT, that it's possible that for some of these patients, perhaps with the 1 or 2 node positive group, that those might receive eventually axillary irradiation alone and no chest wall irradiation. I think the jury is probably still out on those patients who have 3 nodes, where the view might be that those patients continue to need axillary dissection. But we have to be careful about generalizing the results of this trial to practice. But I suspect that's going to be the direction of travel.
Yeah, there is quite a number of questions also coming from the virtual realm about details of heterogeneity between groups. I'm pretty sure this will be presented also in the full publication. Let's proceed with microphone number 2. Brief question, brief answer.
Rachel Rabinovich, University of Colorado. Thank you so much. We've been waiting for this. I'm going to expand on question 6. So today, when patients get sentinel lymph node biopsies, are you applying the results of this study to those patients who have 1 or 2 positive lymph nodes after a sentinel lymph node biopsy?
So we have a pre-specified analysis looking at nodal stasis overall. There isn't a pre-specified analysis looking at examination of patients by number of nodes, but that is possible that that could be done as a post hoc analysis. We are looking at a subgroup, pre-specified subgroup analysis by molecular subtype. So it is possible that if we identified within the molecular subtype subgroup analysis that there were patients who had a higher risk of recurrence, for example, who had a survival of less than 80%, then one might be much more cautious about applying these data to patients who had triple-negative breast cancer. So I think this presentation is not the definitive one. We have to look at those subgroups before we clearly specify to which patients it's applicable and which it's not applicable. But I think it's going to be generally applicable to most of the patients who meet the eligibility for criteria for the trial.
Thank you.
Microphone 3.
Of Miami Cancer Institute, you kind of answered part of my question, which was, did you have access to molecular subtype, molecular profiling data for the ER-positive, HER2-negative tumors?
So we have a tissue archive of over 1,200 patients within the SUPREMO trial, and we will be looking at developing translational sub-studies, in particular looking for molecular markers of breast cancer radiosensitivity. You'll be aware of the recent publication in JNCI of the polar mRNA molecular signature of breast cancer radiosensitivity, which distinguishes a group which do not appear to benefit from radiotherapy with a polar low profile, and a group that do benefit from radiotherapy with a polar high profile. And it will perhaps be interesting at some point to apply these tests to the tissue archive to refine the selection of patients who either do or do not benefit from radiotherapy.
Microphone 2.
Simona Schädelman, MD Anderson Cancer Center. Do you have an idea about why you did not see a distant MET-free survival benefit in your cohort compared to the NCI-CMA20 and the EORTC 22922 trials?
So I think what we cannot separate out, I think, the composite of factors which contribute to the reduction in breast cancer mortality, whether it's better screening, better attention to surgical margins, better pathology, better quality assurance of the radiotherapy. But if you look at the earlier overviews of, you can see that improved systemic therapy with taxanes, Herceptin, and anthracyclines have a significant effect both on local recurrence and on distant mortality, distant metastases. And I think what we're probably seeing is that there is a significant effect in this trial of improved systemic therapy both on local recurrence and distant mortality. And if we look at comparable non-randomized cohorts, the recent cohort from Taylor and colleagues from the Oxford group of over 500,000 women who've been followed over a kind of similar period of time where you see a dramatic drop in mortality, I think these are the same factors which are at play.
Okay, thank you. We have currently 28 open questions in the Slido, so can I urge the presenters to log on and try to continue the public discussion there while we proceed with the meeting. Thank you.
Okay, next speaker will be by Dr. Alan Swaran, who will discuss about 3 previously presented. Please.
So good morning, everyone, and thank you to the organisers for asking me to discuss these very exciting presentations that we've just had. So these are my disclosures, and I think we all know that outcomes for breast cancer continue to improve, and we really need to focus on de-escalation strategies to avoid overtreatment and make sure as clinicians that we're making patient-centered choices, particularly when there are multiple different treatment options with different side effects. And the 3 presentations we've heard earlier address some of these issues. So first of all, the EUROPA study. So this is comparing endocrine therapy to radiotherapy in women over the age of 70 years with low-risk invasive breast cancer. And we know that de-escalation studies have already been done in this group of women before, but most have actually looked at de-escalation of radiotherapy. The results of the CALGB 9343 and PRIME2 trials showed that emission of radiotherapy was safe. There was an increased risk of local recurrence, but no detrimental effect on distant recurrence or overall survival. And I've just presented there the survival curves from the PRIME2 study. There are lots of newer trials now using molecular markers to identify those suitable for emission of radiotherapy, and I've summarized some of them here. Some have already reported and show that emission of radiotherapy is a very safe option. However, all these trials are mandating 5 years of endocrine therapy, and in the PRIME2 trial, the risk of local recurrence was 4 times higher in the no radiotherapy group if the patients discontinued their endocrine therapy. And we all know that adherence to endocrine therapy is very variable and can decrease over time. And what we often find in the clinic is that we make a joint decision with the patient that we're going to omit the radiotherapy, and then the patient returns to clinic 3 or 4 months later, finding that they don't tolerate their endocrine therapy, and we've kind of missed the opportunity to give the radiotherapy. The other important thing to realize is that there's been a lot of changes in radiotherapy fractionation. When most of these studies were set up looking at emission of radiotherapy, it was the radiotherapy that was considered to be the burdensome part of the treatment because it was delivered over 3 to 5 weeks. We've now got very good evidence that partial breast irradiation is safe in this group of women and has less side effects. And following the Fast Forward study, we in Europe certainly have adopted ultra-hypofractionation, so giving 5 consecutive fractions, and this has been shown to be non-inferior to our standard 3-week regime that we used to use. So it stands to reason that there may be some patients that would prefer just to have 5 fractions of radiotherapy rather than take 5 years of endocrine therapy. So this is the design of EUROPA, and what was presented today were the quality of life outcomes at 2 years, a planned interim analysis. And looking at the patient characteristics, most were between 70 and 80 years. 40% did have a G8 score less or equal to 14, meaning that there was some frailty in their performance status. And the majority that had radiotherapy had partial breast irradiation. So the quality of life data Icro has gone through in detail with you, but there were 2 things that I just really wanted to highlight. First of all, this figure here, which I think is quite striking, showing that this decreasing global health score with endocrine therapy happens quite quickly and persists with treatment. And when you look at the adverse events, pretty much all of them were more common in the group that received endocrine therapy, particularly joint pain. The only one that was more common in the group that received radiotherapy was breast pain. And about 22% at 2 years had already switched their endocrine therapy because they were having problems with tolerance, and 12% had stopped completely. So I think this is showing us that radiotherapy can be better tolerated than endocrine therapy in some patients in this age group. And it is a real alternative to single-agent endocrine therapy. And as far as we can tell, although it's only 2-year data, there's no increase in local or distant recurrence in the radiotherapy-only arm. But if you look back to the BASO-2 trial, which compared exclusive radiotherapy to exclusive endocrine therapy in a low-risk group, they did show equivalent local recurrence rates and breast cancer-specific survival. So I'm hopeful that this will become a good alternative for our patients, and I think it's really important that when we talk to patients, we explain the toxicities of both treatments, and really, especially with the endocrine therapy, explain that some patients will get prolonged side effects. So moving to the DCIS study, so this is looking at tamoxifen in good risk DCIS after breast-conserving surgery with no radiotherapy. So the majorities of studies done looking at endocrine therapy of DCIS have given it in conjunction with the radiotherapy. And we see in these cases that there's mainly a reduction in contralateral disease, not so much impact on ipsilateral recurrence. The one trial that did have a group that just had breast-conserving surgery and tamoxifen alone was the UK ANZ DCIS trial, and I've just shown the forest plots here. It did show a reduction in ipsilateral events, but this was mainly affecting the pure DCIS recurrences, not the invasive recurrences. So the study that was presented was analysing data from two trials that were actually set up to evaluate the omission of breast radiotherapy in low-risk DCIS. The first was a single-arm study, so none of the patients received any radiotherapy. The second, the RTOG study, was randomized. So for the purposes of the analysis that was presented, all the patients that were randomized to radiotherapy were excluded. And in both trials, the use of tamoxifen was optional. So most of the patients were over 50, and as it wasn't randomized, there are some imbalances between the two groups. So the tamoxifen group tended to have more re-excisions, and interestingly, the pathological size and grade was actually lower in the group that had tamoxifen compared to no tamoxifen. So what they found was this significant reduction in ipsilateral invasive recurrences, so different from what was found in the UK DCIS study, and they saw less effect on DCIS recurrence. And as we've already discussed, it was surprising that there was so little effect on contralateral disease. But I think it's really important, this decrease in ipsilateral invasive recurrence, because there are studies, such as the Sloan study from the UK, that show that if you develop an invasive recurrence after DCIS, you have a worse survival than those who develop a pure DCIS recurrence. So you can see the invasive recurrences here on the Kaplan-Meier plotter in blue. So we want to try and prevent these invasive recurrences. The other important thing to remember is that 20% of subsequent ipsilateral invasive disease after DCIS are actually new primaries. So this is work that we did as part of the Precision Grand Challenge. And I think this is really interesting because we should think slightly differently about DCIS. And my hypothesis or take from this is that radiotherapy is probably more likely to prevent clonal progression, whereas endocrine therapy may be more appropriate for those at risk of a second cancer. And so my vision for the future for DCIS would be to have a multimodal predictor incorporating not only the genomic assay that we're all striving to find, but also other things like breast density, family history, polygenic risk score, things that will help us tell which patients are more likely to develop a new primary and perhaps would be better off having endocrine therapy. So just before we move from DCIS, I just wanted to mention this trial, which is being run by the Taiwan Breast Cancer Consortium, which is comparing low-dose tamoxifen for 5 years versus radiotherapy. So these will be really interesting results. So finally, the SUPREMO study, looking at postmastectomy radiotherapy in intermediate-risk breast cancer. So just to give a bit of context, there's been a lot of controversy around whether postmastectomy radiotherapy is required in patients with 1 to 3 positive nodes. I've put the results up there from the meta-analysis published in 2014 by the Early Breast Cancer Trials Collaborative. And you can see that they show that in this 1 to 3 positive node group, that radiotherapy reduced locoregional failure and breast cancer mortality. However, there's been lots of discussion about the applicability of these findings with modern systemic therapy, and SUPREMO has gone some way to answering those controversies. So important to look at the study population. It wasn't just focusing on patients with 1 to 3 positive nodes, but also high-risk node-negative patients. And I think the other important thing to note was that 65% of the patients were either node-negative or had only one involved lymph node. And as has already been alluded to, treatment for the axilla has changed. And in this study, if node-positive, patients had to have an axillary clearance, whereas now we would most likely be offering axillary irradiation to those with 1 to 2 positive nodes. So the results. So there was no benefit in overall survival in either the node-negative or the 1 to 3 positive lymph node group. Just a small caveat for this result is that if you look at the 2014 meta-analysis, the overall survival benefit from post-mastectomy radiotherapy was only seen after 10 years. They did show a benefit in local control only in the patients with 1 to 3 positive nodes, and they estimate that this benefit is around about 2%. So how do we interpret these results? And the big question for me is the nodal radiotherapy important? Because these patients only had chest wall irradiation. And I'm sure you all remember this paper from last year. So another meta-analysis from the Early Breast Cancer Trialist Collaborative Group, which showed the benefits of regional nodal radiotherapy. And I just want to show you some of the forest plots there to remind you of the results. So this is breast cancer recurrence, and you can see that they split it down by nodal status. And although the biggest benefit in those that have 4 or more positive nodes, you do see some benefit in those with 1 to 3 positive nodes. You also see a similar trend for breast cancer mortality in the patients with 1 to 3 positive nodes. And finally, this study also showed that medial tumors were the ones that benefited most from the nodal radiotherapy, and those trials that didn't include an internal mammary chain field had less benefit. So my take on SUPREMO is that I agree that we should not be giving post-mastectomy radiotherapy for T2 node-negative patients who've had a mastectomy. I don't think it's completely answered the question regarding the need for post-mastectomy radiotherapy in T3 end-node patients, as so few were recruited. I agree that the benefit from post-mastectomy radiotherapy in the node-positive group is very small, but I don't think this can be generalized to all patients with 1 to 3 positive nodes, especially as only 12% of the patients in the trial had 3 positive nodes. So in my opinion, I think there still is a role for post-mastectomy radiotherapy, including the regional lymph nodes, in patients with 1 to 3 positive nodes if they have high-risk features, such as 3 positive nodes, medial tumor, poor biology. So in conclusion, I think we've heard 3 practice-changing abstracts, and we will go back to our clinic and think carefully about the risk-benefit ratios of our treatments, and also make sure that we make patient-centered treatment decisions, because it's not a one-size-that-fits-all. So finally, I'd just like to say thank you to all the patients that took part in these very important studies. Thank you for your attention.
Okay. Thank you very much.
Okay, so let's move to the next segment of de-escalation. Early oncologic outcomes following active monitoring or surgery, plus minus radiotherapy for low-risk DCIS, the COMET study AFT 25, presented by Eun-Sil Wang from Duke.
Thank you very much. Good morning. I'd like to thank the conference organizers and our moderators for the opportunity to present our trial today. We're presenting today primary outcomes following active monitoring or surgery for low-risk DCIS from the COMET study. Here are my disclosures. As way of background, ductal carcinoma in situ is a precancer or a pre-invasive cancer. In the United States, the estimated incidence of DCIS is about 56,000 new cases annually. And the treatment for virtually all patients who are newly diagnosed with DCIS is surgical excision plus or minus radiotherapy to prevent progression to invasive cancer. Emerging data show that DCIS may, but does not always progress to invasive cancer, presenting a potential opportunity for active monitoring in this very good prognosis group of patients, similar to an approach that's usually widely used for early-stage prostate cancer. The COMET prospective randomized non-inferiority trial randomized patients with low-risk DCIS to either guideline concordant care or active monitoring. The guideline concordant care arm included usual care with surgery at diagnosis with either a breast-conserving surgery or mastectomy, with adjuvant radiation treatment given according to radiation oncologist recommendations. The active monitoring arm included ipsilateral mammogram every 6 months, biopsy for imaging changes based on pre-specified criteria, and guideline concordant care only upon diagnosis of invasive breast cancer during the time of monitoring. Adjuvant endocrine therapy was allowed in both arms. The primary outcome for the guideline concordant care group consisted of any invasive breast cancer detected either at the time of surgery, which is known as upstaging, or if patients recurred during the time of follow-up. Primary outcome for the active monitoring group consisted of any invasive breast cancer on core needle biopsy during monitoring or at the time of surgery. The 2-year cumulative rate of invasive ipsilateral breast cancers were identified at any time following randomization for both groups. The eligibility criteria consisted of women aged 40 or older with a new diagnosis of low-grade DCIS. Patients had unilateral or bilateral disease, and pathology criteria were confirmed by 2 pathologists who agreed the patients were eligible for the study. The patients had to have DCIS without invasive cancer, nuclear grade 1 or 2, and ER and/or PR positive. Patients who had greater than 4 centimeters of calcifications on mammography were recommended to have 2 sites of biopsy to determine that both sites were eligible for participation in the study. Randomization was stratified by age of diagnosis, maximum diameter of microcalcifications on mammography, and DCIS nuclear grade. A few words about the statistical analysis plan. Our primary outcome was the 2-year cumulative rate of invasive breast cancer following randomization in both groups. Our sample size was based on 30% non-adherence to arm allocation overall, because we suspected that with a significant difference between groups, there would be patients in both groups who did not accept their arm allocation. The assumption for the analysis was based on a 2-year cumulative rate of invasive cancer diagnosis of 10% for the guideline concordant group, as based on published literature which included upstaging and recurrence. This was a one-sided non-inferiority bound of less than 5%, higher rate of invasive cancer in active monitoring compared to guideline concordant care. And because we suspected that there would be a degree of non-acceptance of allocation, we had both an intent to treat analysis and a planned per protocol analysis. Here are the primary endpoints of the study, which I'll discuss today. The primary endpoint was a 2-year ipsilateral invasive cancer rate, and the secondary endpoints included 2-year mastectomy rate, breast conservation rate, and radiation. My colleague, Dr. Ann Partridge, will follow this presentation and will present the patient-reported outcomes in her presentation. This is the consort diagram for the study. Patients who were randomized to active monitoring are shown on the left, and overall, 484 women were included in the intent to treat analysis, and 427 included in the per protocol analysis from the active monitoring group. On the guideline concordant care group on the right, 473 were included in the intent to treat analysis, and 246 were included in the 2-year per protocol analysis. We'll now compare the groups based on an intent to treat analysis. Most of the patients who participated in the study were older than 55 years at diagnosis. Most patients were of white descent, and most had grade 2 DCIS. The majority of patients had at least one comorbidity, although it should be noted that this was a relatively healthy population, with more than 30% of patients reporting no comorbidities. Now, for the primary endpoint of 2-year cumulative rate of ipsilateral invasive cancer, we found that this rate was 5.9% in the GCC group and 4.2% in the active monitoring group, with a difference of 1.7%, which was lower in the active monitoring than in the guideline concordant care group. This shows the primary outcome non-inferiority margin on an intent to treat analysis, and shows the difference in 2-year cumulative rate of ipsilateral invasive breast cancer. This is a one-sided 95% upper confidence limit, which was 0.95%. This entered the bounds of non-inferiority, and therefore we met the criteria to deem that AM is not inferior to GCC. Secondary endpoints in the intent to treat analysis included invasive cancer characteristics diagnosed according to the randomization group. You can see here that based on the intent to treat analysis, invasive breast cancer size, HER2 status, node status, and highest grade of invasive cancer did not differ significantly between groups. Most of these patients had endocrine therapy with 65% of GCC and 71% of AM undergoing endocrine therapy. And almost 27% of patients in the GCC group had radiotherapy compared to 7.4% in the active monitoring group. And finally, in the surgery group, we found that 5.5% of patients undergoing GCC had mastectomy versus 3.7% in the active monitoring group. We noted that there were 29.7% of patients who did not adhere to the arm that they were allocated to. So based on a planned per protocol analysis, we evaluated the 2-year cumulative rate of ipsilateral invasive cancer on that subgroup of patients, and this consisted of 673 patients, or about 70% of the patients who adhered to their allocated arm. The 2-year cumulative rate of invasive cancer in the guideline concordant care group on this per protocol analysis was 8.7% versus 3.1% in the active monitoring group. Again, there was a lower diagnosis rate of invasive cancer in the active monitoring group with a difference of 5.6%. Again, looking at a per protocol analysis, patients received radiotherapy up to 48% in the guideline concordant group and 3.5% in the active monitoring group. And the mastectomy rates differed significantly with 8.9% in the guideline concordant care group and 1.9% in the active monitoring group undergoing mastectomy. Finally, we performed an as-treated analysis. You'll note here that patients who had surgery are indicated in blue. Patients who had active monitoring are indicated in orange, regardless of the group that they were initially randomized to. And in terms of invasive breast cancer size, node status, and highest grade of invasive cancer diagnosed, these groups did not differ significantly. So in summary, in this pre-specified primary analysis of the COMET study, the 2-year cumulative rate of invasive cancer was 5.9% for women randomized to GCC and 4.2% for AM. There were no significant differences between groups in invasive tumor size, node status, or tumor grade. And we noted that 31% of participants did not adhere to their arm allocation, with more patients favoring active monitoring. Although there was no obvious imbalance in patient characteristics between groups, we cannot exclude participation bias in this analysis. So at 2 years, women with low-risk DCIS randomized to active monitoring had a non-inferior rate of invasive cancer in the ipsilateral breast compared to those randomized to guideline concordant care. These short-term results are encouraging, but we will need additional follow-ups to determine the long-term feasibility and acceptability of this approach. I'd like to thank the COMET trial participants for their deep engagement and altruism to help find an alternative option for DCIS, and the many physicians across all 100 sites who were enthusiastic and showed immense support for the study. Finally, the funders, which included PCORI, BCRF, and AFT, we could not have done the study without their support, and a special thanks to the incredible COMET team. To learn more about this study, I invite you to go to this publication, which explains more details about our study, just published today in JAMA. Thank you.
Thank you. Well, maybe you have a seat and we discuss after the next presentation, because it's the very same trial, and we will now have the...
Okay. So next presentation will be the same trial, but it's different purpose. Will be by Dr. M. Patrigan. Is the patient-reported outcomes following active monitoring or surgery, radiation for low-risk DCIS in the COMET study. So please welcome.
Thank you. I am honored to present the patient-reported outcomes from the COMET study on behalf of my co-investigators, and I'd really like to thank the organizers and the program committee for selecting this presentation as a testament, I think, to their dedication to infusing the patient voice into this conference. Here are my disclosures. So women with a history of DCIS have been documented to have an overall favorable health-related quality of life in long-term follow-up. However, there are well-documented rates of reduced vitality and mental health in some populations, and heightened anxiety, as well as fear of risk of recurrence, similar to invasive disease, has been seen in previous research. Also, DCIS treatment-related symptoms may be prevalent, including arm symptoms and persistent pain. As we've just heard, there is interest in avoiding surgery for low-risk DCIS, and this led to the COMET study, which, as Dr. Huang just demonstrated, or just showed, demonstrated that active monitoring was non-inferior to guideline concordant care at 2 years follow-up. No prior analyses have prospectively compared patient-reported outcomes among women managed with guideline concordant care, that is surgery, compared to active monitoring with mammograms. And the COMET trial provided an opportunity to do just that. As you just heard, the COMET trial was a prospective randomized non-inferiority trial comparing guideline concordant care to active monitoring. The patient-reported outcomes were a pre-specified secondary endpoint designed to compare the patient voice by group using prospectively collected validated questionnaires at enrollment, 6, 12, and 24 months. The surveys were administered either in person or electronically based on patient preference. We chose 3 major domains and specific instruments reflecting those domains in collaboration with our patient leadership team, as well as with review of the literature. As you can see here, the health-related quality of life instruments used were the SF-36 and the EQ-5D-5L. The psychological emotional instruments were the State Trait Anxiety Inventory, the Center for Epidemiologic Studies Depression Scale, or the CESD-10, and the Quality of Life in Adult Survivors QLACs, where there were 4 items that were adapted to address worries about DCIS. And then finally, we assessed DCIS treatment-related symptoms using the Breast Cancer Prevention Trial Symptom Checklist, which was modified with 8 symptom clusters. We used the Breast Cancer Pain Questionnaire to assess pain in the breast and follow-up, as well as a brief pain inventory. All outcomes were analyzed as continuous scores. However, we also looked at the CESD-10 by its clinical threshold of 10 in screening for depression. Linear mixed effects models were fit to assess changes in scores by group over time, controlling for age. The primary analysis was an ITT analysis, and that was performed using all participants. However, a per-protocol sensitivity analysis included only participants who adhered to their protocol assignment as randomized. You can see the consort diagram of the 957 eligible participants in the ITT primary outcomes analysis. Only 4 were excluded because they had no survey responses from the PRO analysis. We had a 99.5% response rate to at least 1 survey. In follow-up, response rates at each time point exceeded 83%, and a total of 70 women, only 7%, completed only the baseline questionnaire. Response to the 2-year survey did not vary by group. However, Participants who were older, Black, or had higher tumor grade were less likely to complete both the baseline and the 2-year survey. Here are the patient characteristics in the ITT group. You'll note that while the majority of participants were white, there were 16% of participants who were Black. We also had over 50% with reporting at least one comorbidity, and almost 20% were pre or perimenopausal, and the groups were well balanced as randomized. Here are the first results. From a quality of life standpoint using the SF-36, general health was relatively stable and similar to population-based norms, where typically you will see a score of about 50, and they did not differ by group over time. You'll note that clinical significance in using the SF-36 is generally associated with a 2 or more point difference in score. Looking at the mental component summary score and the physical component summary scores, those average scores did not differ by group over time. On the left, you can see the mental component scores, and on the right, you can see the physical component scores. And you'll note that for this presentation, the GCC group is highlighted in blue, and the orange group is the active monitoring group. In terms of physical functioning, this was the only domain in the SF-36 where changes in the score trajectory differed by group over time statistically. Again, you'll note that the clinical significance of this appears to be quite modest. Using the EQ-5D-5L to measure quality of life, the scores did not differ by group over time. Moving on to anxiety and depression, there were overall low levels of anxiety and depression, and there were no differences by group over time as randomized. You can see the average anxiety score by group over time on the left, and the average CESD-10 score by group over time on the right. The probability of depression, however, using the cutoff of 10 or greater using the CESD-10 was numerically higher in the GCC group at each time point and over time, although it did not meet statistical significance. Worries about DCIS using the QLACs revealed that there were no differences between the groups over time, noting that we only collected this data point at baseline and 24 months. Moving on to physical symptoms, overall, there were relatively low average levels of menopausal and body image symptoms reported, and that is interesting considering that nearly 70% of participants in both groups took endocrine therapy. Changes in symptoms did not differ by group over time, either overall or looking at specific symptoms, except that mean pain using the breast cancer pain questionnaire and sensory disturbance domain, the scores were higher at baseline in the no surgery group compared to the surgery group. However, scores were higher in the surgery group versus the no surgery group at 24 months, as you can see illustrated on the right, and this was of borderline significance. In our per protocol sensitivity analysis, including only those participants who adhered to their assigned protocol group, which was nearly 2/3 of patients, overall quality of life, anxiety, and depression did not differ by group over time. The physical component summary scores, physical functioning, role physical domains, however, did differ modestly clinically by group over time. Only certain symptoms varied by group over time as well, and that included arm problems, which were transiently worse at 6 and 12 months in the GCC or surgery group compared to the active monitoring group. Pain scores were lower at baseline in the GCC group and then worsened over time in that group, and this is in contrast to the active monitoring group in which scores were higher at baseline and then improved over time. So in summary, the COMET study PROs demonstrated overall quality of life, anxiety, depression, breast cancer worries, and symptom trajectories were comparable between randomized groups, with no evidence of substantial negative impact of one approach over the other at 2 years follow-up. Thus, for select women considering active monitoring or guideline concordant care for low-risk DCIS, both strategies appear to have only limited impact on the average lived experience of these patients in short-term follow-up. I'd like to thank the COMET study participants, all of the COMET investigators and research staff, the Alliance Foundation trial, and the funders for supporting this study. And if you'd like to hear more details about the PRO analysis, it's published today in JAMA Oncology. Thank you.
Okay, very nice work. It's any questions? Okay, microphone number 3, please.
Hello, John Robertson from Nottingham. Anne and Shelley, I've got some concerns about the study. The first thing is 2 years follow-up for DCIS really is inappropriate, given that this is a constant hazard ratio out to 15 years. But my bigger concern is that, in fact, the reason you see a difference is because of the upstaging of surgery. Everything you see is in those first 2 months. And that's because you've removed 8% of invasive cancers. So by not doing that in the other group, you're leaving 8% of cancers in the treated breast. In addition to that, yesterday's meta-analysis, which Robert Hill showed, which I'm a co-author on, shows that you have a 14% risk of distant disease in patients who get primary endocrine therapy. And that's effectively what you're doing for that 8% of patients. Our guidelines now today are that you should be removing invasive cancers, and that's not what you're doing here. And the difference in your primary endpoint at 2 years is purely because you've missed 8% of invasive cancers in the breast.
Yeah, so thanks very much for that comment. I think it's a really important point of clarification that I need to make sure that everybody understands in terms of this study design. So our intention was to do a fair head-to-head comparison between active monitoring and guideline concordant care. And as you know, all previous studies which have looked at outcome in patients with DCIS have only looked at outcome after the excision has occurred. If we were just to compare patients who had surgical excision to those who did not have surgical excision, it wouldn't be a fair comparison because in one group you're only looking at the invasive cancer rate after surgical excision, and in the other group you're looking at them since the very beginning. So in order to have a fair head-to-head comparison of the two approaches, I would argue that you really need to look at what happens to both groups after randomization, at any point after randomization. I completely agree with you that the invasive cancer rate in the guideline concordant care group is largely due to upstaging. In fact, I made a point of that in my slides. But I think the other thing to note is that even though we would have expected to see that same rate in the patients in the active monitoring group, we haven't seen that yet. And these patients get very close monitoring at every 6 months. And so, you take care of these patients yourself. I would have expected that some of those patients who may have had invasive cancer at the outset would have manifested during the follow-up.
You put them in adjuvant endocrine therapy. Of course they won't see it in that time period.
Yeah, but doesn't that argue that that might be a reasonable alternative to
That's
doing
what the meta-analysis yesterday showed that it isn't. You get a 14% increased distant disease over a period of time.
Yeah. I think that, if I'm not mistaken, is for all comers with DCIS, and in this particular study, we really confined our patient population to low risk.
Okay, number 2.
Vogel, New York. For Ann Partridge, I'm really interested in how much of the excess loss in some of your quality of life measures in the active monitoring was due to patients who had invasive cancer on GCC care. And, I'm sorry, with the other way around, on GCC care, on guideline concordant care, because they had breast cancer and they got treated for breast cancer. So one of the fair things we should do for a patient like this is say it doesn't seem to be that we need to be in any hurry, and here is what you will avoid in terms of toxicity for treating active breast cancer, and at least for 2 years it seems to be pretty good. So it would be very nice to see what the PROs show for the ladies who had invasive breast cancer, and then to show for the patients, if you didn't have invasive breast cancer, you'll go along fine with even less toxicity.
Thank you, Dr. Vogel, for that comment. I think you're absolutely right that we may be seeing that, and I do look forward to future analyses looking into those who developed invasive disease and specific subsets otherwise.
Just a comment for Dr. Wang. When you first presented this study a few years ago, I discussed it with friends, patients, family, and they said, how do you know you're not missing a cancer? And the answer is you don't. Now we know in this population, because of the randomized nature of the study, about how many obvious cancers we're missing. Now, whether those are important or not is the question we need to find out later, probably in 8 or 10 years.
I couldn't agree with you more, and the reason that we did an early analysis was to just try to allay those fears that had been articulated at the very beginning of planning for the study. I think there were many who thought that we would see an inordinate number of very advanced breast cancers in the group that had active monitoring because they did not undergo immediate surgery. And I do acknowledge that this is a short-term follow-up, but I think it's reassuring that what many people were afraid would happen with active monitoring, in fact, has not occurred. As I said, I think this is too early to change practice completely, but you would have to see a lot more invasive cancers in the active monitoring group to equal what we see in the per-protocol analysis in the surgery group. So I think this brings up a provocative question of whether for low-risk DCIS, endocrine therapy may be just as good as undergoing surgery. And since a third of women undergo mastectomy for DCIS, I think it's not an inconsequential question.
Okay, final, number 4, please.
Congratulations for the publication. So I just have an easy question. The patients in the monitor group, they are willing to take the endocrine therapy forever, or if we extend the follow-up, finally they will have the local therapy in 5 or 10 years?
Yes, I think the question had to do with the duration of endocrine therapy in patients who choose to have it in both arms. The standard recommendation for endocrine therapy as adjuvant treatment for DCIS is 5 years for patients who have surgery. We don't have any data that show that in active monitoring or in the guideline concordant care group there would be additional benefit beyond 5 years. So for the study itself, if patients chose to take endocrine therapy, we suggested discontinuing it at 5 years.
Thank you.
Okay, time is up. Thank you very much.
Okay, thank you.
Okay, the next presentation will be no axillary surgery versus axillary sentinel node biopsy in patients with early invasive breast cancer and breast-conserving surgery. Final primary results of the intergroup Sentinel Mama in SEMA trial, and Tora Freimer from Rostock presents it on behalf of his co-investigators.
Dear Chairman, thank you for your introduction. Thank you for giving me the opportunity to present the primary outcome data of the SEMA trial today. Here are my disclosures. In the lower part, you can see the statement related to this surgical trial. SEMA is one of four ongoing de-escalation trials evaluating complete omission of axillary surgery in patients with upfront breast-conserving surgery. Results of the sound trial were published last year demonstrating that omission of axillary surgery in patients with smaller breast cancer up to 2 centimeters is not inferior to sentinel lymph node biopsy. We have previously published 2 secondary outcomes of the SEMA trial. First, a quality assurance process was
implemented, focusing on radiotherapy planning and axillary contouring. The central review of this review for the first 3 cases at each site was published in 2020. Second, the results of the quality of life analysis for the complete Ensema population were published in 2022 and showed that patients with no sentinel lymph node biopsy have a benefit regarding arm symptoms and functioning. The goal of the Ensema trial is to demonstrate that complete omission of axillary surgery does not result in inferior invasive disease-free survival compared to standard sentinel lymph node biopsy in early breast cancer with upfront breast-conserving surgery. Here, the design and inclusion criteria of the Ensema trial, we enrolled clinical node-negative patients with a tumor size up to 5 centimeters. All patients underwent breast-conserving surgery and postoperative whole breast irradiation. A planned target volume to the axilla or the use of high tangents were not allowed according to the protocol during postoperative radiotherapy. The first randomization was performed in a 1-to-4 allocation because we wanted to have more patients on the right side as candidates for the second randomization. In case of 1 to 3 macrometastasis in the sentinel lymph node, these patients were randomized between sentinel lymph node biopsy alone versus completion axillary lymph node dissection. The 5-year invasive disease-free survival is the primary outcome for the first randomization. Please note the results of the second randomization are not part of this presentation. The trial was open for recruitment in Germany and Austria. The analysis of the primary endpoint was performed on the per-protocol set due to the non-inferiority design of the trial. The non-inferiority was tested based on the confidence interval of the hazard ratio from the Cox proportional hazard model to exclude the hazard ratio of 1.271 for the primary objective. This upper end of the confidence interval is corresponding to the absolute decrease in 5-year IDFS rate from 88% expected for the standard arm to 85% just accepted for the no surgery arm. Age, clinical, and preoperative tumor size were predefined stratification factors. Adjusting for the asymmetrical randomization, 851 events and 5,200 per protocol patients were needed in total for the first randomization. Assuming a 5% dropout rate, who have to be excluded from the per protocol analysis, about 5,500 patients need to be randomized into the first part. The final officially analysis was planned event-driven when 851 events occurred. A time-driven analysis was pre-planned after a follow-up for 5.5 years for the last recruited patient in case of lower event rate than expected. Here you can see the assignment of the 5,500 eligible patients. The main reasons for dropout from the ITT set were secondary mastectomies and withdrawal of consent before final surgery. The main reasons for exclusion from the per protocol set were the omission of postoperative radiotherapy and axillary surgery not according to the randomized arm. The node positivity rate was 15% for the sentinel lymph node biopsy population. 3.4% of patients were diagnosed with micrometastasis only. 11.5% of all patients showed macrometastasis in the sentinel lymph node, but only 0.2% of all patients had 4 and more involved sentinel lymph nodes. The baseline characteristics are well balanced between the study arms. The median age was 62 years. Please note, only 11% of the trial population was aged below 50 years. The great majority of patients were recruited with a preoperative tumor size up to 2 centimeters, 90% of the population, and with low or intermediate tumor grading, more than 95% of the population. The percentage for the subgroup with invasive lobular carcinoma was nearly 13%. The dominant intrinsic subtype according to the receptor status was the hormone receptor positive, HER2 negative subtypes representing 95% of the entire trial population. Here are the primary results after a median follow-up of 6.1 years as per protocol analysis. The ENZIMA trial is positive and met its primary endpoint, demonstrating non-inferiority for patients with complete omission of axillary sentinel lymph node biopsy. The 5-year invasive disease-free survival was 91.9% in the no sentinel lymph node biopsy arm versus 91.7% in the standard sentinel lymph node biopsy arm, with a hazard ratio of 0.91 and an upper end of the confidence interval of 1.14, clearly below the pre-specified non-inferiority margin of 1.271. The primary endpoint was also met when analyzing the attention to treat set. Again, no difference between the curves, with an upper end of the confidence interval below the pre-specified margin was observed. We observed 525 primary events for this endpoint analysis. This number was lower than expected, so that the time-driven analysis was performed after 5.3 years follow-up for the last recruited patients. There were no major differences between the study arms. For instance, the frequencies for distant relapse was 2.7% in the no sentinel lymph node biopsy arm and 2.7% in the standard arm. It's important to report the rate for axillary recurrences in such a trial for de-escalation of axillary surgery. As expected, the rate for axillary recurrences was slightly higher in the no sentinel lymph node biopsy group, 1.0% versus 0.3% in the standard arm. But as you can see, the absolute numbers of events are very low. The overall survival was very good for the ENZIMA population. Again, no difference between the study groups was observed. The 5-year overall survival rate was 98.2% for the no surgery arm versus 96.9% for the standard arm, with a hazard ratio of 0.69 and a wider confidence interval due to low event numbers. If we look to the forest plot for the invasive disease-free survival in subgroups, no substantial heterogeneity was observed in hazard ratios between subgroups, except for the small subset of patients diagnosed with high tumor grading. Of special interest, patients with a preoperative tumor size greater than 2 centimeters or patients with the diagnosis of invasive lobular carcinoma had no disadvantage when avoiding complete axillary surgery. Our conclusions. The ENZIMA trial enrolling 5,500 patients significantly demonstrated that complete omission of sentinel lymph node biopsy in clinical node-negative patients with early breast cancer and scheduled for breast-conserving therapy did not result in inferior outcome. Patients recruited for the ENZIMA trial had a very good overall survival with 97 versus 98% at 5 years according to the treatment arms. This de-escalation concept, avoiding complete axillary surgery, is suitable for patients with an age 50 years and older and with low tumor characteristics like low or intermediate tumor grading and hormone receptor positive, HER2 negative subtype, and a preoperative tumor size up to 2 centimeters. I want to say thank you to all patients and all participating study sites. The GBG, the German Breast Group, did excellent work on project and data management, monitoring, and statistical analysis. The ABCSG coordinated the Austrian study sites. And finally, I have to say thank you to the German Cancer Aid Foundation for fully funding of this pure academic trial. And I have to say thank you to all my colleagues in Rostock for supporting over the last 10 years this trial project. If you want to see more details about this primary outcome analysis, you can read our full publication released by the New England Journal of Medicine later today. Thank you very much for your attention.
Thank you very much. Microphone 4.
Nick Murray, Adelaide. Thank you. I'm sure that's going to change practice. I'd just like to ask you about grade 2 tumours. So we know a reasonable proportion of grade 2 on core will be upgraded to grade 3 at tumour resection. What would your advice be for that group post avoidance of axillary surgery?
According to the ENSEMA trial, I think we don't have enough data to recommend no axillary surgery in high-grade tumor patients because this number is very, very low, only 3.6% in our trial. So I would focus to low and intermediate tumor grading. And if you have an upgrade, then you have to routine praxis as previously.
Thank you.
Microphone 6.
Questions. Do you have any data on the genetic risk and sensitivity to endocrine therapy of the patient, either with MIND-ACT or with the genomic health recurrence score?
I'm sorry, we don't have used multi-gene assays like Oncotype DX or MammaPrint. These were not available during the recruitment period between 2015 and 2019 in Germany and in Austria. Sorry.
Second question, could you tell us more about the systemic therapy that you offered these patients who didn't have sentinel node biopsies? It wasn't you who offered them, it was the medical oncologist wherever they were treated. One of the reasons to do axillary sampling is because some of us treat the node-positive patients considerably more aggressively than the node-negative patients. So in a sense, if everyone got very aggressive therapy, sure, you don't have to take the nodes. You're only worried about axillary recurrence, not about systemic recurrence. I assume they all got adjuvant hormones.
Thank you for this question. There was not enough space on the slides to present this, but you will find a nice table in the full publication as supplementary file. Short summary, there was no difference regarding endocrine therapy and the use of adjuvant bisphosphonates. But of special interest, there was a difference for the chemotherapy application rate. And it was a little bit surprising for us to see a lower rate of applied chemotherapy in the no sentinel arm. 10.4% versus 12.9%. This difference was significantly and is in contrast to the SOUND trial. If you look to the SOUND trial, patients in the no sentinel group received more chemotherapy than the patients in the standard arm. This is a different result between the two trials.
Speaking of the sound, because questions flow in on the Slido here, can you clarify, did all ENSEMA patients receive preoperative ultrasound?
Yes, this diagnostic workup was mandatory. All patients received axillary ultrasound.
Okay, thank you. Discussion continues virtually, and I think we now have a thank you very much. Great trial.
Okay, next speaker will be Dr. Singh, is this discussion of the abstract general session 2, 5, 6, and 7. So please welcome Dr. Singh.
Good morning, and thank you to the conference organizers for the opportunity to present, as well as congratulations to the abstract presenters for these exciting and highly anticipated results. These are my disclosures. So we've come a long way in terms of de-escalation of breast surgery from the days of the Halsted mastectomy. NSABP B04 established the safety of modified radical mastectomy, and subsequent NSABP studies as well as Milan group studies established the safety of breast conservation surgery. And today in 2024, I stand here as a surgeon discussing opportunities for omission of breast surgery. So first we'll start with the COMET study, specifically the primary endpoint that was presented by Dr. Huang. And the COMET study, as a reminder, was a randomized pragmatic non-inferiority trial that enrolled patients from 2017 to 2022. Patients had low-risk DCIS, specifically grade 1 or 2, that was hormone receptor positive. And they were randomized in a 1-to-1 fashion to guideline concordant care versus active monitoring. The primary objective was 2-year ipsilateral invasive cancer rate, and that was estimated to be 10% in the guideline concordant care arm, with the hypothesis that active monitoring may be higher. The non-inferiority margin was set at a margin of less than 5%. And so here we can see the consort diagram with 995 patients who were eligible and enrolled. There were 484 in the active monitoring arm on the intention to treat analysis, and 473 in the guideline concordant care arm. However, when we look at the per protocol cohort, we see that in the active monitoring arm, there was 11.8% non-acceptance of allocation. And in the guideline concordant care arm, there was 48% non-acceptance of allocation. Now, overall, this was around 30%, which was estimated by the authors as part of the study design. In terms of the primary endpoint, non-inferiority of active monitoring compared to guideline concordant care was demonstrated in both the intention to treat analysis that you see at the top and the per protocol analysis that you see below that, with rates in the intention to treat analysis of 5.9% 2-year invasive cancer rate in GCC versus 4.2% rate in the active monitoring arm for a delta of 1.7%. Now, I'd like to point out, as has been discussed previously, that majority of the cancers that were invasive cancers that were diagnosed in the GCC arm were really due to upstage, as you see that sharp increase on the curves within a few months of enrollment. Additional treatment information that was presented included about 26% of GCC patients who received radiotherapy and 7.4% in the active monitoring arm. Endocrine therapy, which is an important consideration, 65.5% of the GCC arm received some amount of endocrine therapy in 2 years versus 71% in the active monitoring arm. Unfortunately, the majority of the invasive cancers that were diagnosed were small, with a mean 0.45 centimeters, and most of those who had some sort of axillary evaluation demonstrated node-negative disease. The second abstract presented by Dr. Partridge was on patient-reported outcomes. And again, I'd like to congratulate the authors and the conference organizers for recognizing the importance of PROs and presenting these along with the primary endpoint. And we see that they reported patient-reported outcomes that were collected at baseline, 6, 12, and 24 months using validated questionnaires evaluating 3 key domains. 99.5% completed at least one survey, and there were responses available at each time point in over 83% of the population, which is really quite remarkable for surveys. So here we see the results for the PROs. In the quality of life domain, there were no differences in general health, mental and physical component scores, or quality of life. Physical functioning did differ by group over time, however, was not clinically significant. In terms of psychological and emotional symptoms, there were low levels of anxiety and depression, though there was an increase in depression, particularly in the guideline concordant care arm over time, though not statistically significant. I think importantly, there were no differences in worry about DCIS between baseline and 24 months, and that's really important to see. And then in terms of DCIS treatment-related symptoms, we did see mean pain scores that were higher at baseline in the active monitoring group, but then higher in the guideline concordant care group at 24 months, essentially reversing. The per protocol analyses confirmed these findings that were seen in the intention to treat analysis, and in addition showed worse arm symptoms at 6 and 12 months and pain in the guideline concordant care group, but that did improve over time. So to put this into context, there are a number of other studies that are looking at and have looked at active surveillance. Specifically, I'm highlighting the ones that were designed as randomized trials initially, and so they really signify the interest in active surveillance for low-risk DCIS. Very similar designs with patients in their 40s enrolled on these studies with asymptomatic or screening mammography detected DCIS. Low to intermediate grade, although LORD did enroll low grade only. And LORIS and LORD both enrolled regardless of ER status. Now, COMET, as you can see, enrolled 995 patients with the initial goal of 1,200 versus LORIS from the UK, which enrolled 227 of the planned 932, and LORD, which is still actively enrolling. The primary outcomes are very similar in terms of ipsilateral invasive cancer. However, they're being measured at different time points. And as you heard in the COMET study, the goal was also to demonstrate safety of this option. So I'd like to highlight the LORD experience. This initially was designed as a randomized trial, but in 2020, that trial design was changed due to patient preference, actually being more so for active surveillance. And you can see here in the 377 patients at that time that were enrolled, 76% actually chose active surveillance versus 24% who chose standard care. And these are very similar to what we're seeing numbers-wise in the COMET study. And they surveyed those patients in terms of their motives for a preference. And what you see is that the patients who chose active surveillance, they felt that treatment may not yet be necessary. There was also a high level of trust in the surveillance strategy, and they wanted to avoid side effects. The standard of care arm, or those who chose that, had cancer worry, and they felt that there was a perceived certainty with doing surgery and additional treatment, and they wanted closure. So to summarize, the COMET study demonstrates a low rate of 2-year invasive cancer, 5.9% in the guideline concordant arm, majority of which was upstaging, versus 4.2% in the active monitoring arm. Similarly, there were small invasive cancers in nodal status between the two groups, as well as grade. And overall, the PROs were comparable between the groups over time in both per protocol and intention to treat analyses, really demonstrating that there's no significant negative impact in group. But there are still additional considerations when we think about active surveillance for DCIS. We certainly need longer follow-up, and I think that was raised previously and is very important as we think about recurrences really typically occurring much further out than 2 years. There are pre-specified analyses planned at 5 and 7 years, and we will eagerly await those. In terms of acceptance of allocation, as I demonstrated, there were a number of patients who, in the guideline concordant arm particularly, that did not receive per protocol treatment. But I think to spin this kind of in a more positive light, I think this really does indicate that there's significant patient interest in active surveillance of DCIS. And that's really important when we think about engaging patients in treatment of their disease. The role of endocrine therapy in active monitoring, I think we await more data regarding adherence to endocrine therapy, how long these patients took it, and then certainly there are questions about how long should they take it if they're doing active monitoring. I know the protocol did recommend 5 years, but we know that there is a drop-off in terms of adherence over time with endocrine therapy due to side effects. And then the questions of healthcare costs and the frequency of additional imaging and biopsies and how that plays into potential PROs certainly comes up. And finally, there are translational endpoints that are planned, including development of a genomic signature to identify high-risk DCIS that'll use the COMET and LORD cohorts. And so what are my take-home points for active surveillance? One, we do need more evidence for this to become standard of care. But if we revisit the original hypothesis of the COMET study, that was that management of low-risk DCIS using an active monitoring approach does not yield inferior cancer or quality of life outcomes compared to surgery. And I think that these data do support the importance of continuing to evaluate active monitoring as a treatment strategy for low-risk DCIS. Informing patients and really actively engaging in shared decision-making is really necessary, and this could become a part of our toolkit for DCIS. And then I think this may be appropriate today for use in select patients such as those who are high risk for surgery. So switching gears for a moment to de-escalating axillary surgery, which has really been where the surgical field has been moving in the last couple of decades, from ALND, which is maximally invasive, associated with quite a bit of morbidity, to sentinel lymph node biopsy that's been demonstrated to be safe in a number of settings based on a number of landmark trials, to now maybe not doing any axillary surgery. And as a reminder, sentinel node biopsy has always been a staging technique rather than a therapeutic intervention. And so the NCEMA study presented by Dr. Reimer enrolled patients from Germany and Austria from 2015 to 2019, And this was a population of patients with clinical T1, T2, and 0, demonstrated both clinically and sonographically negative axilla that were planned to undergo breast conservation surgery followed by postoperative irradiation. And the primary objective of the study was to compare invasive disease-free survival between the no axillary surgery arm versus sentinel node biopsy arm, and that was a 1-to-4 randomization. So here's the consort diagram, and as you can see, over 5,100 patients were enrolled in the study for the first randomization point, with over 1,000 in the no sentinel node arm and just over 4,100 in the sentinel node arm. And there were about 300 patients who were excluded for several reasons, including 38 who did not receive treatment per their randomization arm. And so that leaves us with just over 4,800 patients in the per protocol analysis. And so for their primary endpoint, this was time-driven since there were fewer events than expected, and that was 5.5 years after the last patient was randomized. With a median follow-up of 73.6 months, here you see essentially about 92% 5-year invasive disease-free survival, and therefore demonstration of that no sentinel lymph node biopsy is non-inferior to sentinel node biopsy. And so if we put this into perspective, comparing it to the SOUND trial, which was published in 2023, these are similar trials, though of course the 4-to-1 randomization in ensema does result in a higher sample size. The populations are similar, except that SOUND enrolled patients with tumors that were 2 centimeters or smaller, versus ensema, which did go up to 5 centimeters. That being said, 90% of the tumors were 2 centimeters or smaller. And of course, both studies did include negative axillary ultrasound. The age question was very important to see in today's data, and median age was 62 years in ensema. And while we don't have menopausal status, we know that about 11% were under the age of 50. In terms of survival, the survival is excellent in both. Now, SOUND did measure distant disease-free survival at 5 years, and that was about 98% versus ensema, which reported invasive disease-free survival as their primary outcome at 92%. But overall survival at 5 years in both studies was around 98%, so excellent. And that really supports the idea, again, that this is a staging technique rather than a therapeutic intervention. Recurrence rates, good to see that they were both low in terms of local and axillary recurrences. And so ensema adds to the evidence that sentinel node can be omitted in select patients, and we see excellent survival outcomes and low rates of recurrence. But again, there are additional considerations. And so, as was previously stated, I think this is appropriate for smaller tumors, those that are 2 centimeters or smaller, as we know that higher rates of sentinel node positivity exist with larger tumors, and that has implications in adjuvant therapies. Furthermore, there was a low percentage of non-hormone receptor positive HER2 negative tumors, so really we don't know what to do with small HER2 positive or triple negative breast cancers that are undergoing upfront surgery. The role of preoperative imaging is also still a question. While at my institution, we do it routinely for everyone, that may not be standard workflow for everyone, and how does that fit in if we're going to omit this? And also, there is a low percentage of lobular histologies, and we know these are hard to detect on imaging. And so what are the implications of sentinel node omission? Well, first of all, I think definitely positive sentinel nodes impact adjuvant therapy decisions regarding radiotherapy and medical therapies. We know premenopausal patients may be recommended chemotherapy and/or CDK4/6 inhibitors. And in terms of radiotherapy options, patients may be limited if they don't have axillary staging in terms of partial breast irradiation or being enrolled on clinical trials that do require sentinel node evaluation. And so I think this is still a staging modality that is necessary for many patients. And so the take-home point is that shared decision-making with patients and the multidisciplinary team is critical when determining who we can omit the sentinel node biopsy in without compromising their care. And so my final slide is just to summarize these, that we do have additional data on omitting surgical treatment in low-risk populations, but there are questions that remain. These bring us closer to individualizing and optimizing the care of patients with breast cancer, and it's really important to engage patients when we're making these decisions. And finally, I'd say COMET and other similar studies highlight the challenges of randomized trials and de-escalation and opportunities to design patient-driven clinical trials. Thank you.
Thank you.
Okay, in the next segment, we will discuss obesity and prognosis in early-stage breast cancer, and on behalf of EBCTCG, I call Hong Xiaopan to the stage to present the data of more than 200,000 women in almost 150 trials.
Thank you. It's a great pleasure to present the EBCTCG data on obesity and prognosis in early-stage breast cancer for the early breast cancer trialist collaborative group. First, I have nothing to disclose. Obesity is known to be associated with somewhat worse prognosis, but the strength of this association could depend on ovarian activity and on estrogen receptor positivity. We aim to relate obesity to first distant recurrence rates in various different categories of women. We analyzed the data of 200,000 women with early-stage breast cancer in 147 randomized trials. Among these women, 26% of them were obese, that is BMI 30 or more, 6% post-menopausal, and 77% with ER-positive disease. We use Cox regression to stratify for trial and treatment and adjust for age and tumor characteristics to assess the association of body mass index and the risk ratios of first distant recurrence and of mortality. Here is our overall results. This graph shows the association of BMI with risk of distant recurrence among the 200,000 women with early breast cancer. Horizontal axis represents body mass index, vertical axis represents risk ratio of first distant recurrence. We divide women into 5 groups according to their BMIs. BMI under 20, that's underweight, 20 to 25, normal weight, 25 to 30, overweight, and 30 to 35, obese class 1, and BMI 35 or more. As you can see, there's a very nice, roughly log-linear relationship between BMI and the risk ratio of distant recurrence. The overall adjusted risk ratios of distant recurrence is 1.06 per 5 units different in BMI. A difference of 5 units in BMI is substantial. If we take the top 2 groups of women with BMI over 30 and then put them together as obese, which is the standard definition of WHO, and if we also take the bottom group of women with BMI under 25 and put them together as a lean, which is our own definition, we can compare the risk of distant recurrence between obese and the lean. The risk ratio is 1.17. The mean BMI in obese women is 35 and 22 in lean women, a difference of 12 units, which is a big difference. So how will this association vary in different categories of women? And this first plot shows the risk ratio with its 95% confidence interval per 5 unit difference in BMI by type of systemic therapy among the 200,000 women. Here you can see chemotherapy only, endocrine therapy only, both or neither, high BMI, high risk of distant recurrence. But the risk ratio in each type of systemic therapy is entirely consistent with the overall 1.06 with little heterogeneity. So the strength of the association of BMI with distant recurrence is independent of systemic therapy. Here is another forest plot, shows the risk ratio per 5 units different in BMI by menopausal status. In premenopausal women, the risk ratio is 1.08, but in postmenopausal women, the strength of the association of BMI with distant recurrence is somewhat weaker. The risk ratio is 1.05. Although the difference is statistically significant, but it's not striking, and the risk ratios in both pre- and post-menopausal women are qualitatively very similar. So what about the difference in absolute risk of distant recurrence? And this Kaplan-Meier graph compares the 10-year risk of distant recurrence, comparing obese and lean in premenopausal women, and separately for women with nodal negative disease and nodal positive disease. As usual, nodal positive disease has worse prognosis than nodal negative disease. In premenopausal women with nodal positive disease, comparing obese with lean, the 10-year risk difference is 4%. So instead of 25.6% 10-year risk in lean women, 29.7% risk in obese women. In nodal negative disease, and the 10-year excess risk is 2% between obese and lean, 12.2% risk for obese women and 10% risk for lean women. Move to postmenopausal women here on the right. And in nodal positive disease, the 10-year risk of distant recurrence among lean women is 25.3%. In obese women, is 27.6%, 2% high. 10-year excess risk between obese and lean with nodal negative disease is 1%. Here is another forest plot which shows the risk ratio per 5 unit difference in BMI by ER status. The risk ratio is 1.06 in both ER poor and ER plus disease with little heterogeneity. So the strength of the association of BMI with distant recurrence is approximately independent of ER status. We have run various analyses to assess the effect of tumor characteristics on proportional strengths of association of BMI with distant recurrence. We find little instructions. Results for breast cancer mortality were similar to those for distant recurrence. For overall non-breast cancer mortality, the association with BMI was similar to that in general population, which is a U-shaped association. And you may remember 10 years ago, our preliminary analysis of part of this dataset generated two hypotheses. With substantially updated dataset, these two hypotheses are now tested. As I've just show you, one is now confirmed and the other is now strongly contradicted. For hypothesis 1, somewhat less effect of BMI if post-menopausal than if pre-menopausal. Yes, this hypothesis is now confirmed. And hypothesis 2, zero effect of BMI in ER-negative disease. No, this hypothesis is now strongly contradicted. So in summary, in pre and more weakly in post-menopausal women, there is a continuous association of its entire range of BMI with distant recurrence rate. But the typical absence of the differences in 10-year risk only moderate, about 2% risk difference with 12 unit change in BMI, for example, in the case of obese versus lean women, or about 1% risk difference with 5 unit change in BMI, such as by lifestyle interventions. Here are my acknowledgements and also list of my co-authors for this presentation, and I thank you for your attention.
Okay, thank you very much. From online, Shao, what happens to distant recurrence rate if obese women lose weight after the diagnosis? Can you say something about the dynamic changes?
We have no such information, and we only really relate to the BMI at the diagnosis to breast cancer prognosis. But even without such information, and it seems, and we assess the association of BMI with breast cancer prognosis over different time period after women diagnosed with breast cancer. And the risk ratio is remarkably stable over, say, 1 to 2 years after diagnosis, or after 5 years, even after 10 years. The risk ratio just stay pretty much the same as 1.06. So that just indicates probably either not many women lose weight afterwards, or even they lose weight, and the effect on the prognosis is not that obvious.
Okay, don't be impolite. Just say we don't have the data. Number 5.
Thanks. This is Jiang from Peking Union Medical College. And I have a quick question. Is BMI measured at baseline?
Yes.
Is BMI measured at a baseline?
Yes, and just at the diagnosis, just only near probably a few months before diagnosis.
So that means all the results are based on the assumption that the BMI is not going to change over time during follow-up.
Well, we haven't assumed anything. I mean, it's just an observation. We simply just relate the BMI merges at the time of diagnosis to later. And even so, as I just mentioned, and so just that the association with the later risk ratio is pretty much stable.
Thank you.
John Robertson, brief question. Number 2.
The difference in the postmenopausal women, have you taken account of the fact that as they get older, there are competing causes of mortality, more so in postmenopausal than premenopausal, from the obesity, cardiovascular disease, diabetes? Does your analysis allow for that and the difference between the effects in pre- and postmenopausal women?
Our analysis have not considered the competing risk in the model, and we just censor women at time of non-breast cancer. And but actually, just most women will die from breast cancer. The competing risk of cardiovascular disease will tend to dilute the absolute risk, not really relative risk. So the relative risk of 1.06, that's pretty much the same.
Okay, thank you very much.
Okay, the next speaker will be by Dr. Michael Erickson. It's a long-term imaging-delivered AI risk model for primary prevention of the breast cancer.
So thank you very much for inviting me to present. So I will switch gears a bit. We'll talk about healthy women and assess risk in the long-term 10-year risk. And the purpose using image data and artificial intelligence, and the purpose for that is to potentially offer these women a lifestyle intervention or medical intervention already at study baseline, so they do not need to develop a breast cancer in the first case. So let's see if this one works. Doesn't advance. Okay, so here are my disclosures related to patent on image data and risk reduction therapy response. So the idea here is that we know that breast cancer incidence has steadily increased over the last several decades, and primary prevention and interception of breast cancer that could potentially reduce the incidence, the increasing incidence of breast cancer. And we need to have an efficient risk tool to identify high-risk women who may benefit from primary prevention. And that preferably should also be efficient and easy to implement. So, but if we make a recap of how this typically is done, so the last several decades of research in the field have identified a number of risk factors. We know the age of the woman, BRCA mutation, high mammographic density, if you have benign breast disorders and families of breast cancer, of course, we know also about medium penetrated genes, and we can also combine common variants into a polygenic risk score, like the BCAC risk score. We know about nulliparity and lifestyle-related factors and reproductive factors. And what one are doing is combining them in different ways. We have heard about different models here during this conference that want to take some of these factors and combine them into risk score. And they are typically referred to as lifestyle, family history-related risk models. But the concern is that there's some limitations in the ability to identify, or in this case, separate those women who will develop breast cancer during the coming 10 years from those who will stay healthy, usually reported as AUC. And here we see an example of very well-known GAIN model, Cusick model, and the BCSC model. So the question then has arose, and could we use image data to improve this, or maybe even start using, from the basis to start using image data? And if you look into the history of this, mammographic density is a very well-known risk factor, has been studied over several decades. And in the later decade about that has also been incorporated in several models such as GAIT, Cusick, BCSC, and Canrisk, the Boadicea model. But we have been thinking a bit differently. It has been shown now in several studies that there are mammographic features beyond density that could potentially be used associated with risk. And they have mainly been used for assessing the short-term risk, and we were one of the first to develop such model as well, but they have a different purpose. So, but what could happen if we could identify those factors and combine them into mammographic scores and create a risk model basically on that? And then, of course, we need to be very, very careful as we use artificial intelligence, that we are really clinically validating them, checking replication very carefully about related to confounding factors such as how they perform in different screening populations and so on. So for this reason, we collaborated with Mayo. So it's a Mayo-Karolinska collaboration. And the aim was to develop and externally validate an image derived based on image data, but it uses artificial intelligence to predict the risk of breast cancer. And now I'm 10-year follow-up. And then we also need to have some clinical comparison with the Cusick is one of the most well-known, and this is the Cusick version with the density in that, and that we had access to in the Karolinska data only. So what we typically do is that we start with large cohorts. In this case, it was together with Professor Céline Vachon in Mayo, where she gathered data of 33,000 women in the Olmsted County. And then we typically do smaller subsets of data, so it's easy to work with that case cohort. It can be different study designs. Here it was approximately 6,000 women, 1,100 breast cancers in the age 35 to 94. Then we also have our Swedish cohort, Kalmar cohort with Per Hall, and in Sweden, and there we have access to 70,000 women, and we created a similar case cohort there with 2,000 breast cancers, and we further separate them into training and validation, and I will report on the validation part here with about 3,000 women. And we follow the women for 10 years from healthy women to development of breast cancer. So here, so the total cohort is then 10,000 women, and we have the Olmsted, the Mayo Clinic data, where we can see that we have approximately 4,800 women in the subcohort and 1,100 breast cancer cases. And we see very typical ages as we expect in breast cancer screening, 54, and some few years older women on average in breast cancer cases. And of course, we have a much higher BMI in US studies compared to Swedish studies. And we saw about 60% of women to be postmenopausal. That was defined by an 8 cutoff. And race is very important, but we had limited information of that. In Olmsted, we saw more than 90% of women being white. In Kalmar, we didn't have that information, but we know that well, the 97% of the women had a European origin. And then we calculate the risk score, the 10-year risk score, and we saw in the subcohort in the healthy group 3.8% 10-year risk, and it depends on that there are more in situ cancers in the US. And we had in common 3.14% lifetime risk, and we followed the women for 10 years. So as we're using artificial intelligence, so that becomes quite complicated. So, and one usually combines different types of neural networks. So we had what we refer to as a breast view model that look into the different 4 views that we have: left, right, CCMLO, interception ResNet model. And it was trained to extract features associated with the breast cancer throughout the 10-year period. And then we had a combined model look into the mammographic case or the views together, mobile net model that was trained with a similar purpose. And then we make a 10-year prediction using a different type of machine learning model, using those 2 outcomes from the first, and then predict 10-year risk based on that. So if we look into the results, so we have 3 types of results that are of interest. First is the ability to separate cases from controls, referred to as AUC. And we can now see that we have a substantially higher AUC. We follow women from 5, 6, and 10 years in the onset, in the external validation unseen of the model. So we had 10-year AUCs of 0.72. And if you also look in our internal data set in KAMA, we saw similar results there, AUC of 0.72. That can be compared with the tricusic in this case, which had an AUC of 64 at 10 years. And we see that it's very stable results throughout the different years from 5 to 10 years. So we see that we have a very consistent behavior throughout the years, follow-up up to 10 years of a better performing model, image-based model based on AI. And what is more interesting, it was many numbers. I just stated the result here, that we saw very similar results between ER-positive breast cancer and ER-negative breast cancer. Of course, if we are thinking about the intervention of endocrine treatment, then that would target ER-positive breast cancers, but there are potential for this model to be used also for primary prevention of ER-negative breast cancer. And we had very limited data on ethnicity. It was related to the US study, and we saw similar results in white and non-white women. And it was also a stable result in different age groups. Throughout women below age 50 and in the typical screening age, and then also above age 70. So the second factor that we need to consider is the calibration of the model. If the model predicts a certain number of breast cancer, we also want to observe that in the data. So here we can see that if we look into the invasive breast cancer only, so the actual cumulative hazard measured actually the events as they occurred, then we saw about 3% 10-year events in the Olmsted data set and 2.7% in the KAMA data set. And we get a bit different numbers when we also account for the in situs. But interestingly, the model picked up those differences in incidence rates, as is referred to here as the expected to observed ratio. One is the idle number, and we got an expected to observed rate of 0.99 in the Olmsted data set, and the same 0.99 in the KAMA data set. So it really picked up those differences in features as study baseline that then translated into different incidence rates throughout the 10-year follow-up. And a tricusic was a bit over-predicting here, but more importantly, it was quite about 70% over-predicting in women below age 50, and it was also under-predicting in women above age 50, while the AI model was well calibrated throughout the different risk groups. And the third is that we need to also comply with some clinical guidelines, and there are, in Europe, we would use NICE guidelines, and here I give an example adapted for US PSTF, and one are using the absolute risk score and make different cut points for what one considered to be high risk. In this case, 6% was used. if women have a 6% doubled the average risk of breast cancer in the 10 years, then they were considered to be high risk. And we can see that 18% of the women were at high risk, and that also captured at study baseline 43% of breast cancer. And in the Swedish setting, it was slightly lower proportion, 15% of breast cancers identified at baseline, 15% of women, and that translated to 41% of breast cancer cases. And that can then be compared to Thyroxic, where only 15% of breast cancer were captured at study baseline. So in conclusion, so we see that also if you're using an image-based model, image-derived AI-based model to predict tenure risk, so that can be compared to traditional risk models, and we can see that it has better discriminatory performance, it has better calibration, and it also have a better clinical risk classification. And the really important part here is the generalization of the models, of course. And what was interesting in this study is that we had different mammography vendors. We had a vendor from GE, Hologic, Siemens, Philips, and Fuji, and we saw similar performance throughout those different vendors. And we had also different incidence rates that were picked up very nicely by the model, and also there were different screening routines that were picked up very nicely by the model. So we can see that we could predict already at study baseline about 40% of breast cancer that was captured at baseline in about 15 to 80% of women at high risk. And for that reason, we believe that we have a good starting point to have a long-term image-derived AI-based model that has a potential to inform clinical decision by identifying high-risk women who may benefit from a risk-reducing intervention. And that could be lifestyle changes or medical intervention. But of course, it doesn't stop there, so we are already now working on further steps. One concern with AI-based model is that they are black box model. They are also complicated with millions of parameters, so we cannot get an intellectual oversight of them. So we need to find another way of explaining them, and we are right now doing some mediation analysis to see how traditional risk factors such as weight, family history are mediated and in part explained by this AI risk score. And we are, of course, working on further validation of the model as well, and also looking to potential expansions of the model, including genetic determinants. So, and the overall idea is that we have that, in addition, that we think that such a 10-year risk model that targets primary prevention could potentially be an additional service to breast cancer screening. That is, of course, all about early detection, but this could be an additional service that could be added, and all the purpose is, of course, to reduce the incidence of breast cancer. With that, I would like to thank you very much for the listening. Thank you.
Okay, I think the only time is for only one question. Number 3, please.
Dan Hayes, University of Michigan. Very nice talk. The question is, your entire study was AI versus the model versus the Cusick model. Have you looked at if you combine those, do you get even better results? I mean, there have been recent AI studies for general medicine diagnosis that showed, if anything, throwing the doctor into the AI made it worse, not better, because of our judgment being poor. So I wondered if you've looked at the two together.
Yeah, absolutely. So we traditionally, already when we started to do this about now 8 years ago, so we developed what we refer to as Model 1, Model 2, and Model 3. And Model 1 is the image-based only. Then on Model 2, we add additional factors, lifestyle factors, and also genetic factors. And we know that the combination will improve the model. However, it will not be dramatic. That is what we have seen so far. So it is a matter of balance of the simplicity of the model of using that and the potential to slightly improve the accuracy. But we will report exactly on these combinations later on as well.
Okay, thank you.
So the next presentation is by Avantika Gupta from Memorial Sloan Kettering Cancer Center in New York on ApoPEX3 mutagenesis induces resistance-promoting genomic alterations
in breast cancer.
Hello, everyone. My name is Avantaka Gupta. I'm a postdoctoral research associate in Dr. Saraj Chandalapari's lab at Memorial Sloan Kettering Cancer Center. And today I'm really excited to share our work where we've identified a role for APOBEC mutagenesis in driving therapy resistance in breast cancer. All right. Through the work of several people in the audience, we understand how breast cancers evolve under the pressures of therapy. This is best depicted by alterations in genes such as ESR1 and NF1 that are virtually absent in primary disease, but very prevalent in metastatic cancers. These and other ways of how these breast cancers evolve highlight the underlying genomic instability of breast cancers, and we hypothesized that studying these underlying mutational processes can help us identify biomarkers for these highly evolvable cancers and identify targets to treat these adaptable malignancies. Over the last 10 years, the concept of mutational signatures has been developed as a tool to study the mutational processes that a cell has been exposed to in its lifetime. These can include environmental factors as well as endogenous factors. In looking at thousands of cancer genomes, researchers have identified different types of mutational signatures, and one example is the single base substitution, or SBS signature. This signature represents the 96 potential point mutations when looking across the whole genomes of a cancer sample. So when in the PECOG data, researchers looked at mutational signatures in breast cancers, two signatures emerged as being the most prevalent outside of the clock-like signatures, and these are SBS2 and SBS13 that are both associated with the activity of APOBEC enzymes. APOBECs, particularly APOBEC3s, are cytosine deaminases that recognize cytosines in the TCN motifs on single-stranded DNA and lead to C2G and C2T mutations that eventually lead to SBS13 and SBS2. We wanted to understand the clinical and biological implications of APOBEC mutagenesis in breast cancer, and for that, we turned to a large clinical cohort of close to 4,000 high-quality samples from patients with breast cancers. These had undergone matched tumor normal sequencing using the MSK impact assay. In addition to the rich genomic information, this cohort includes detailed treatment history and long-term follow-up, allowing us to perform association studies between APOBEC mutational signatures and biological and clinical outcomes such as disease progression, treatment response, and resistance mechanisms. We started by looking at the exposure of mutational signatures across our whole cohort. In around 2,800 samples where we could confidently call mutational signatures, we saw that APOBEC mutational signatures were highly prevalent, and this was true across all subtypes of breast cancers. Moreover, we saw an enrichment of APOBEC mutational signatures in metastatic and post-treatment settings compared to treatment-naive primary settings in hormone receptor positive as well as triple-negative subtypes, highlighting an association with advanced disease in these breast cancer subtypes. To take a closer look at the timing of activation of these mutational signatures, we looked at a cohort of close to 500 matched hormone receptor positive HER2-negative patient samples with pre- and post-treatment samples. And from the post-treatment samples that were APOBEC dominant, we identified that 87% of them had some exposure to APOBEC mutagenesis before therapy, suggesting that these mutational signatures can be present from early on and might dictate the treatment outcomes. So we looked at this very question and found that in hormone receptor positive cancers, APOBEC3 dominant tumors had worse progression-free survival on first-line endocrine therapy plus CDK4/6 inhibitor therapy, independent of the ET partner used. So this suggests that the genomic instability driven by APOBEC mutagenesis can confer resistance to standard frontline therapies in this disease setting. And while these data are highly compelling, we learned from Dr. Kalin yesterday that correlation does not equal causation. So we next wanted to study if the presence of APOBEC mutagenesis can actually cause these resistance phenotypes. For that, we turned to preclinical models and introduced APOBEC mutagenesis in ER-positive treatment-sensitive T47D cell line by overexpressing the two major APOBEC enzymes A3A and A3B, along with their catalytically inactive mutant controls. When we culture these cells long-term in vitro, we see that the wild-type overexpressing cells accumulate APOBEC mutational signatures shown here in red, and these are the same mutational signatures that we see in human cancers. These signatures were not accumulated in the control cells, so using these APOBEC active and APOBEC inactive cells, we next subjected them to various treatments to try and understand if APOBEC mutagenesis has an effect on treatment response. Starting with the CDK4/6 inhibitor palbociclib, we see that both the APOBEC active cells in red and the inactive cells in gray initially start by responding to the treatment and suppressing growth, but over time, the APOBEC active cells are able to develop resistance and grow up under continuous treatment. This was also true for the other CDK4/6 inhibitor abemaciclib, as well as the estrogen receptor degrader fulvestrant. In these models, we've exogenously overexpressed APOBEC, so our next question was to understand if the endogenous APOBEC activity is also able to promote this resistance. And for that, we identified cell lines that had endogenous APOBEC activity, and then as a complementary experiment, we performed knockouts to regulate or to suppress APOBEC mutagenesis. In these HER2-driven models, APOBEC activity was also able to promote resistance to tyrosine kinase inhibitors, lapatinib and neratinib. Collectively, these data highlight that APOBEC mutagenesis can promote resistance to various therapies in breast cancer. So our next question was to understand the molecular mechanisms of APOBEC-driven resistance, and for that we subjected our cell line models to whole genome sequencing. Here as an example, I'm showing a cell line that acquired a loss of heterozygosity on chromosome 13 upon A3A overexpression. When these cells were subjected to abemaciclib, they further acquired deleterious mutations in the RB1 gene. And this double hit led to a complete loss of RB protein expression and made the cells insensitive to CDK4/6 inhibition. This can be seen by a lack of cell cycle inhibition and a 30-fold increase in IC50 values. So we went back to our clinical data and looked for RB1 mutations in our APOBEC dominant and non-APOBEC dominant cohorts. Interestingly, we found the same truncating mutation at Q217 as being the most enriched in APOBEC dominant cohort that we found in our cell line models. And there's one thing that I would like to highlight here, that these mutations, including all the red highlighted mutations, are actually APOBEC context mutation at the same TCN motifs that these enzymes recognize, really showing here that APOBEC mutagenesis is driving resistance promoting alterations. So the obvious next question is, how do we target these mutational processes to prevent the onset of resistance? Currently, we do not have reliable ways to target APOBEC mutagenesis in the clinic, so we turned our attention to try and identify biomarkers that are potentially enriched in APOBEC dominant population and could be used as indicators for existing targeted therapies. In hormone receptor positive HER2 negative patient samples, we saw an enrichment of oncogenic SNVs in PIK3CA in the APOBEC dominant population, and this is an indication for PI3K alpha specific inhibitors. Upon taking a closer look, we actually found enrichment of helical domain mutations, which are also APOBEC context at E542K and E545K, along with the most enriched second site mutation at E726K. This prompted us to look for double mutations in PIK3CA, and indeed we saw a significant enrichment of double PIK3CA mutations in our APOBEC population, suggesting that these tumors might be more sensitive to PI3K alpha specific inhibitors, as has been shown by the work of Dr. Vassan and colleagues. As a final vignette, I would like to highlight that we also see a large proportion of APOBEC dominant tumors being showing high tumor mutation burden, and that can be seen in these pie charts, where approximately 70% of hormone receptor positive breast cancers that are APOBEC dominant have high TMB, which is an indication for immune checkpoint blockade across solid cancers. So as an exploratory analysis, we identified a small subset of patients who were treated with this indication, and interestingly, we found that APOBEC-dominant tumors had a high disease control rate at 6 months when receiving anti-PD-1 immune therapy in earlier lines of treatment. These preliminary data led us to hypothesize that the presence of APOBEC mutagenesis might sensitize tumors to anti-PD-1 immunotherapy, a hypothesis we're now testing in preclinical and clinical settings. To summarize, our work has shown that APOBEC3 mutagenesis is a prevalent mutational process across all breast cancer subtypes, and our data show that these signatures are enriched in metastatic settings, but I would like to point out that these signatures can be present in pretreatment and primary disease as well, suggesting that they can dictate tumor outcomes from early on. And indeed, we do see that APOBEC-dominant tumors have worse progression-free survival outcomes on endocrine therapy and CDK4/6 inhibition therapy. Our preclinical data established a causative effect of APOBEC mutagenesis in driving resistance-promoting alterations. And finally, our large and well-annotated clinical data indicate vulnerabilities like double PIK3CA mutations and high tumor mutation burden in APOBEC-dominant tumors that could potentially be targeted using existing therapies. In the end, I would like to thank everyone who contributed to this work, Drs. Mara and Gadzo for leading the clinical and bioinformatics side of the project, Dr. Chandalapati for his mentorship and inception of this work along with Dr. Harris, all our collaborators at MSK and beyond, everyone at the lab, our funding sources, and all of you for your attention. Thank you.
Thank you very much and congratulations. Questions? Number 4.
Thank you. Nice presentation. I was wondering if you have looked also at the concomitant mutation present in estrogen receptor alpha.
Right, we have, and so the most common ESR1 mutation that we see being enriched in APOBEC-dominant tumors is actually the E380Q, which is the APOBEC context mutation. The other Y537S and activating mutations are not APOBEC-dominant mutations and hence are not enriched in APOBEC-dominant tumors.
And in which domain?
It's the ligand-binding domain.
Ligand-binding domain.
Yeah.
That's what I supposed. Thank you.
Very good. Number 6, final question.
I'm curious whether you've looked for synthetic lethality with APOBEC activity and whether you could find something else that might treat the original problem rather than later acquisition of mutations.
That's a great question and something we're actively doing in the lab right now. So there has been some work done by others in the field where they've found inhibition of CHEK1 and ATR that is synthetic lethal with APOBEC mutagenesis. But there is a poster in the session, tomorrow, from Dr. Ruben Harris's lab who are talking about synthetic lethal interactions with APOBEC3B specifically.
Okay.
Thank you so much.
Thank you very much.
All right. The next presentation will be by Dr. Art Metzger. A randomized open-label phase 3 trial to evaluate the efficacy and the safety of palbociclib plus anti-HER2 therapy plus endocrine therapy versus anti-HER2 plus endocrine therapy after induction treatment for hormone receptor positive, HER2 positive metastatic breast cancers.
Good morning. I'd like to thank the organizing committee for the opportunity to present the results of our study. And on behalf of my co-authors, I'm honored to present AFT38 PATINA. PATINA is a randomized open-label phase 3 study designed to evaluate the safety and efficacy of palbociclib when added to anti-HER2 therapy and endocrine therapy for patients diagnosed with advanced breast cancer. I have no financial relationships to disclose. As a way of background, approximately 20% of patients diagnosed with breast cancer overexpress HER2, and half of these patients are also called ER positive. Anti-HER2 therapies have significantly improved survival outcomes, but resistance to therapy remains inevitable for the majority of patients with advanced disease. There is a strong rationale for blocking CDK4/6 in HER2-positive disease. The cyclin D1 CDK4 axis is essential for initiation and maintenance of growth in HER2-positive cancers. This same axis drives resistance to the HER2 pathway blockade. So this combined CDK4/6 and HER2 inhibition has shown to be synergistic and have a profound anti-tumor activity in preclinical models. And we all know that palbociclib is an approved agent for the treatment of advanced ER-positive breast cancer. So this picture here illustrates the rationale for blocking HER2 and CDK4/6 pathway. And we can see that the HER2 and CDK4/6, they converge at the tumor suppressor protein TSC2. And once we have the combined CDK4/6 and HER2 inhibition, we see a profound suppression of our phosphorylation and mTOR activity, and this translates into efficacy and forms the rationale for our study. So Patina enrolled patients diagnosed with metastatic ER-positive, HER2-positive disease. Patients were not treated with prior lines of therapy in the first-line setting and received 6 to 8 cycles of trastuzumab-based chemotherapy. So this is similar to what we do in our clinical practices with the Cleopatra regimen, where patients get 6 to 8 cycles of THP. At some point, we drop the taxane, and patients continue on the Herceptin and pertuzumab. So they basically enroll patients and randomize patients upon completion of this induction regimen, and patients who had a CR, PR, or stable disease, and randomized 518 patients to palbociclib plus anti-HER2 therapy and endocrine therapy, or anti-HER2 therapy and endocrine therapy. The stratification factors of this study are important, which include pertuzumab use, and here it's single versus dual HER2 blockades, the prior use of anti-HER2 therapy in the neoadjuvant setting or adjuvant setting, the response to this induction therapy, CR, PR, or stable disease, and the type of endocrine therapies with fulvestrant and aromatase inhibitor being the options allowed in this study. Patina was designed with the PFS assessed by investigator as the primary endpoint. The study had in the design a 90% power to detect a minimum hazard ratio of 0.667. Final analysis, which I'm presenting here today, took place after 269 events, and we passed 2 planned interim analyses at this point. Overall survival is a key secondary objective, and I want to highlight here that the final overall survival is to be planned and to take place only after 247 events. Patina is a study that enrolled from June 2017 through July of 2021. We enrolled 518 participants across 8 countries listed here in this map. And I want to share with you that this is a study for which I got the results last Thursday. So while I'm very excited to share the results here with you, I don't have all the fine details polished for this presentation, and I do apologize for that. Here we have the consort diagram of the study. We screened 630 patients, randomized 518 to palbociclib, anti-HER2 therapy, and endocrine therapy, or into the control arm with anti-HER2 and endocrine therapy. 9 patients withdrew before starting treatment and are not included in the safety analysis. All patients were included in the intention to treat analysis. The median age of our study population was 53 years old. The majority of our patients were white, and the median number of cycles of this THP prior to randomization was 6 and balanced across arms. It's important to say that the overwhelming majority, 97% of patients were treated with dual anti-HER2 blockade, 90% of patients were treated with aromatase inhibitor, 28% of patients enrolled in Patina were never treated with anti-HER2 therapy in the early stage setting, and this includes the majority of patients diagnosed with de novo metastatic disease. The response defined by the investigators with the induction therapy was high, as we know, and 68.5% prior to randomization. Here we have our final progression-free survival curves. We can see in the red curves the superiority of the palbociclib-containing arm shown in red, with the median progression-free survival of 44.3 months when compared to 29.1 months in the control arm. The hazard ratio is 0.74, which translates into a 26% reduction in risk of having a PFS event, with a highly significant p-value of 0.0074. I want to bring your attention here to the beginning of the curves, where we see an early separation of the curves, and this continues over time. When we look at 60 months, we're seeing an absolute improvement that's close to 10%. The median follow-up of this population at this stage is large, it's long, and it's 52.6 months. When we look at the PFS by the stratification subgroups, the magnitude of treatment benefit is maintained by prior anti-HER2 therapy in the early stage setting and according to the response that they had to the induction phase, CR or PR versus stable disease. Here we have a slide with graphics showing the confirmed overall response and clinical benefit rate. I want to bring to your attention here that this is a response evaluated from the time of randomization, after patients have already had a THP and a 68% response rate. So this is an additional response, and we can see on the left, the confirmed overall response is greater with palbociclib, reaching 30 versus 22%, and the same for the clinical benefit rate, 89 versus 81. The overall survival data is immature at this stage, with 119 events out of the 247 planned. The median overall survival has not been reached for patients randomized to palbociclib, and it's 77 months for patients in the control arm. The 5-year overall survival estimate is 74.3% for those treated with palbociclib and 69.8% for those in the control arm, with a hazard ratio point estimate of 0.86. Now let's review the toxicity data of our study. This table brings us the adverse events grade 2 or higher that happened in 10% of patients. Neutropenia, fatigue, and stomatitis were more common in the palbociclib-containing arm. Grade 3 neutropenia was the most common adverse event. We believe this to be consistent to what we know from the toxicity profile of palbociclib. Additionally, diarrhea was more common in the palbociclib-containing arm, with grade 2 or 3 diarrhea happening in 26 and 11% of the cases versus 10 and 2% in the control arm. Importantly, the incidence of adverse events grade 4 or higher were similar across the study arms. Treatment discontinuation due to adverse events were reported in 7.5% of patients in the palbociclib arm. There were no treatment-related deaths reported in either arm of the study. So our results really reinforce the strong scientific rationale for overcoming resistance to anti-HER2 therapy and endocrine therapy with the addition of palbociclib. Palbociclib, when combined with anti-HER2 and endocrine therapy, demonstrated a statistically significant improvement in PFS for this patient population in the first-line setting. And importantly, this regimen had a manageable toxicity profile and without new safety signals. So how do we put that into our clinical practice? I would say that the PATINA phase 3 study demonstrated a clinically meaningful improvement in PFS among patients diagnosed with ER-positive, HER2-positive disease. The median PFS in the control arm of our study is 29.1 months. This far exceeds what we had expected. And in spite of that, we're seeing a 15.2 months improvement. It's more than a year of improvement with the addition of palbociclib. The toxicity was manageable. And I would argue that palbociclib, when added to anti-HER2 and endocrine therapy, may represent a new standard of care for patients diagnosed with ER-positive, HER2-positive breast cancer. I would like to thank all patients and families who participated in this study, all the investigators and staff from all participating sites, including all my colleagues at the Dana-Farber Cancer Institute in Boston, members of the Data Safety Monitoring Board, A big thank for the Alliance Foundation trials and all participating groups listed here below with the logos who have joined this academic collaboration over many years in a study that was difficult to conduct. I'd like to say a special thank you to Professor Monica Bortognoli, who was the head of Alliance when we designed the study, and for her support to put this collaboration together. And finally, for Pfizer to trust in this academic industry collaboration and for their support for this important clinical trial. Thank you so much.
Number 6, please.
Chaudhary from Medical College of Wisconsin. Excellent data, very exciting. So prior to randomization, all of these patients received taxane with trastuzumab and pertuzumab. In clinical practice, a lot of times we see patients with HR positive and HER2 positive disease that don't present with a really high burden of disease and may not necessarily get the taxane portion. A lot of times we would start them with just the trastuzumab, pertuzumab, and an AI. So I wanted to ask around those patients who may not receive chemo at the forefront, what are your thoughts about incorporating this regimen in those patients?
Thank you so much for your question, and I think it's a clinically relevant question, and I fully agree that we have those patients for which we don't feel like giving them chemotherapy up front. While the study didn't test this directly, I would argue that this data is quite compelling, and once we have this as an approved regimen, I would be in favor of using this in these special situations.
Great. Thank you.
Yeah, number 6 again.
Good morning, congratulations. Stefan Glück from Miami Beach. I have a biostatistical quick clarification, please. In your sample size calculation, the assumption was to reach a hazard ratio of 0.667, and at the end, you presented it was reached at 0.74. Sure, it's statistically significant and it's clinically meaningful, I agree, but what is the discrepancy? So can you comment on it, please?
Well, thank you. Thank you so much for your question. I just want to clarify that for the statistical design of the study, when I said the hazard ratio of 0.667, this is the minimum detected hazard ratio as part of the statistical calculation. And our results with a hazard ratio of 0.74 indicate that the study is statistically significant. So it's more of a statistical terminology for the sample size calculation.
Okay, thank you.
This late-breaking abstract is now discussed by Sarah Herbert.
Good morning, good afternoon now. I'd like to thank the organizers for inviting me to be here to discuss these data at the 11th hour. It's a wonderful opportunity and very exciting. So the sentinel understanding that HER2 is driving 20% or so of breast cancers led to the development of multiple HER2-directed therapies, including 8 that are approved here in the United States. Data like these on the right side that were published by the ESME group show that these therapies have significantly improved overall survival for patients with this very aggressive disease subtype. But because of the wide acceptance that HER2 is the driving force of this disease subtype, the focus has been on developing therapies that target HER2 and subsequent development of other novel targeted therapies that hit other pathways that may have crosstalk has not been as aggressive. And in fact, our current treatment algorithms for HER2-positive metastatic breast cancer almost exclusively are based on HER2-targeted therapies. Other than use of endocrine therapy in some patients with hormone receptor co-expression, little attention has been paid to PI3 kinase pathways and other pathways that may be implicated in the development of resistance of disease. We have ample evidence that crosstalk does occur between ER and HER2, and in fact, a number of very nice trials that have been conducted showing that adding endocrine therapy to HER2-directed therapy does improve outcomes. And Shao published this work that Dr. Metzger just showed you, showing that inhibiting both CDK4/6 and HER2 does maximize suppression of TSC2 phosphorylation, leading to a more complete shutdown of S6RP phosphorylation, inhibition of RB, and reducing cellular proliferation. So similar to the patina that forms on copper over years, the elegant body of work leading to the data that you saw today has been going on for more than 15 years. I know that was a stretch, I was trying. About 15 years ago, Rich Finn from Denny Slayman's lab published these data, which is preclinical proliferation in vitro assay data, looking at the activity of palbociclib as a single agent across a broad panel of heterogeneous breast cancer. The HER2-amplified breast cancer cell lines are denoted in dark blue, and as you can see, many were sensitive to single-agent palbociclib in the in vitro setting. Further work went forward to show in other labs that the addition of palbociclib to HER2-directed therapies improves or increases apoptosis and diminishes cell viability. Neil O'Brien and Denny Slayman's lab published this nice work looking at abemaciclib across the same panel of cell lines, showing again benefit or induction of or reduction of proliferation in HER2-positive breast cancer cell lines, shown in the orange there. And in BT474 trastuzumab-resistant and non-resistant xenograft models shows the combination of abemaciclib with trastuzumab and tamoxifen yielded reduction in tumor volume. And Shao also did elegant experiments that were published showing in a transgenic mouse model with inducible HER2-driven mammary cancer, as well as BT474 and a PDX model, the benefits of combining trastuzumab and abemaciclib. What about the clinical evidence? We also have a large volume of work. I haven't shown everything, but just to acknowledge some of the more notable studies, including Moniker, Sarah Tolaney put together this elegant trial comparing abemaciclib, trastuzumab, and fulvestrant, or abemaciclib, trastuzumab, two chemo-free regimens in heavily pretreated HER2-positive, hormone receptor-positive metastatic breast cancer against chemotherapy of investigator's choice with trastuzumab. Now, before I saw the data, I was sure that trastuzumab chemo was going to win. I thought this was a bold experiment, but actually the progression-free survival was about 2.5 months better with the non-chemo triplet regimen. The objective response rate was also more than doubled in the right upper corner there. And an analysis based on intrinsic subtyping indicated that you might be able to select the patients with the best outcome from this approach, and that is the luminal subtypes. The final overall survival was trending strongly in favor of the abemaciclib arms as shown here. The Patricia Solti clinical trial was a study looking at palbociclib in 3 cohorts, just focusing on the 2 hormone receptor-positive cohorts, B2 and B1. Palbo was combined with trastuzumab, and in cohort B2 with trastuzumab and letrozole, leading to a PFS of 6 months of more than 40% in both, a median PFS of 5 to 6 months, and an objective response rate of 14 to 21%. What was really interesting from this study was the intrinsic subtype analysis, and now you can see actually the PFS for the luminal A and B subtypes was actually best, hitting 8.2 to 10.6 months. And this led investigators to open cohort C of this clinical trial, which enrolled exclusively patients with luminal A or luminal B HER2 positive, hormone receptor positive metastatic breast cancer, and boldly compared palbo-trastuzumab endocrine therapy with treatment of physician's choice, which was TDM1 or chemotherapy-based treatment. The trial was closed early after 73 patients were randomized due to low recruitment. The patients in the treatment of physician's choice arm primarily received TDM1, although some received chemo trastuzumab or endocrine trastuzumab. Patients allocated to the standard arm could be re-randomized to help with the statistics. 7 patients did this. This was a fairly heavily pretreated patient population, and the luminal subtypes for pre-screened patients represented close to half of the patients enrolled. And this study did show an improved investigator-assessed progression-free survival with the use of palbociclib, again compared to trastuzumab with chemotherapy or other therapies. The secondary endpoints indicated an improved objective response rate, and as well, an important finding was the time to response appeared to be similar for patients in the palbo non-chemotherapy arm. And then the DETECT-5 study was a randomized phase 3 study that was just presented recently at ESMO in hormone receptor positive, HER2 positive breast cancer. This study began as a question of whether or not patients after induction could omit induction chemotherapy, similar to the question we had earlier, and just give patients endocrine therapy HP versus chemo HP. After they enrolled 124 of patients, they amended and added ribociclib to both treatment arms. So it's not a randomization to ribo. Everyone got it after that time point. And in this study, you can see the chemo-free regimen seemed to do very similarly to the chemo-containing regimen, both in terms of progression-free and overall survival. And then this exploratory analysis looking at ribociclib versus no ribociclib, the efficacy you can see is better with ribociclib. So these are certainly interesting data and hypothesis generating. So now let's turn to PATINA. The study design is shown here. I would just highlight, as Dr. Metzger said, the majority used pertuzumab. Prior trastuzumab was used in 71%, and the objective response rate was almost 70% prior to patients coming on. I would like to highlight that the clue that this data was going to be very intriguing came from the median duration of treatment that you could see in the patient disposition. These patients were on therapy a lot longer than we saw the PFS from Cleopatra of 18.7 months. I thought it was interesting that there were more patients coming off of the control arm due to consent withdrawal and refusal, and I thought that might have skewed the results, but when you weigh that more patients were coming off of palbo for AEs and other reasons, it ends up being fairly balanced. Now, these data are impressive. I heard some people gasping or sighing when this Kaplan-Meier curve was shown. I did so last night at about midnight as well when I saw 29.1 months is quite high for the control arm. And so I sat there scratching my head about how could this control arm look like this? And I pulled up the old papers, Cleopatra, for example. The median PFS was 18.7 months. And in that study, 90% of patients were trastuzumab naive. So why doesn't the data look better? And one thing, Matt Getz and I were talking last night about PATINA, well, endocrine therapy wasn't allowed in Cleopatra, so the patients with ER co-expression didn't receive endocrine therapy. That might have skewed the results, plus they allowed hormone receptor negative, HER2 positive. The PERTAIN study was a trial looking at adding pertuzumab to trastuzumab in an AI. In this study, investigators were allowed to use chemo per their choice. It wasn't randomized. Again, the PFS was 20.6 months only in this all hormone receptor positive, HER2 positive disease. And if you break it out by use of chemo, you see we're still not getting to where Patina reported. Moreover, 72% of the patients had no prior trastuzumab, so the numbers should have looked better, and endocrine therapy was used by all. So what dawned on me about 1 in the morning was that the randomization for this study occurred after induction chemotherapy, and this may be what's going on here. Those patients who experienced disease progression during induction or screening were not included in the study, and those are the patients with de novo treatment resistance. So look at Cleopatra on the left and Pertain on the right, and the proportion of patients who come off around month 6 or 5 when induction chemo would be ending. You're losing about 20 to 25% of your patients. These patients weren't represented in Patina, and eliminating these patients with resistant disease is likely enriching the enrolled patients for the luminal subtype. So it's kind of a nice way to molecularly select your patients who would be appropriate for this particular treatment. I think it's very elegant and pretty cool, but maybe you won't agree with me. Now looking at the median PFS in the Palbo arm, this is incredible, and this really is historic, I would argue. Moreover, the final overall survival of over 6 years, just looking, it's more than 6 years. So again, this is historic and very important data. I won't go through the adverse events. I don't think there was anything that worried me in terms of the adverse event profile, but of course we're awaiting patient-reported outcomes, which I'm sure are going to be part of future analyses. So speaking of the future, I do want to move on to the frontline standard that is likely going to change very soon. The DESTINY-Breast03 Kaplan-Meier curve for PFS is shown here. The PFS was 28.8 months, which was quite high, and this is in pre-treated patients. So it's not hard to imagine that DB09 will be positive, making T-DXd the standard of care, first-line regimen for HER2-positive disease. The question thus is begged, do all patients need to be on T-DXd until progression of disease, or can we use an induction strategy similar to docetaxel or paclitaxel, and then molecularly select patients for a maintenance strategy that will preserve quality of life? Now, this slide here is actually an homage to my mentor, Dr. Slayman. This cartoon appears in almost all of his slide decks. But he usually says we need to move away from a one-size-fits-all approach to breast cancer. I think it's time for us to move away from a one-size-fits-all approach to HER2-positive breast cancer. In summary, today we heard definitive proof that there are benefits to targeting more than just HER2 in HER2-positive breast cancer. The authors are to be congratulated and the patients are to be thanked. These data serve as the finishing touch of an elegant body of work, one to which many have contributed. CDK4/6 inhibitors, in my opinion, should be considered as part of the armamentarium for our patients. But nuanced patient selection is going to be needed. We need more biomarkers and patient-reported outcomes. And there is strong rationale for us to be testing additional targeted therapies in HER2-positive breast cancer and design smart clinical trials to find and identify the right treatment for the right patient. Thank you.
Thank you, Sarah. And this concludes a fantastic general session too.